Hey guys, what's up? This is Stephanie and welcome back to my channel today. So in the video today, I'm going to be doing an OB-GYN end of rotation review. So OB-GYN end of rotation exam review. Hopefully this video is helpful for you. For those of you who are currently in your clinical year, you're about to start your OB-GYN rotation, or you are preparing for your end of rotation exams and don't know what to study or what to use. Hopefully this video is helpful. A little bit about me real quick. I'm currently a second year student. PA student. I already finished all of my end of rotation exams. I'm currently in my 8th clinical rotation. I'm currently in my elective rotation, so I don't have an end of rotation exam right now. So I'm currently just studying for the PAN since I'll be taking that soon in December. So this will hopefully be helpful for you and for me. Also throughout the video, I'll be sharing some pearls of clinical practice. So what I recommend when you're in clinic. Also some information that I remember, high yield information when I was studying, whether it was topics that I kept seeing on the exams that I was taking or on the practice questions I was taking. The reason why I decided to make this video is that when I was studying for my EORs, I always looked on YouTube since I use YouTube a lot to study. I'm a very visual person, or I like to listen to podcasts. I didn't find anything for PA school or PA students. There was a lot of things for medical school, like their shelf exam reviews, but there's nothing for PA school. So hopefully this video is going to be helpful for you guys. And just real quick, what did I use when I was studying for my OB-GYN rotation? So I really recommend the Physician Assistant Exam EOR exam review book. It's great. I'll list the link below. I really recommend that textbook. The prices tend to range. I know sometimes it'll be 40, sometimes it'll be 60 or 70. It just depends when what time you purchase it or when you purchase it. And I purchased it off of Amazon. Basically, it has a review for every EOR, and this is what I used. I also used in conjunction PANS Prep Pearls, which I think every PA student has, and it's a must for PA school, so I really recommend also PANS Prep Pearls. I also used Osmosis. If you're a visual person, I really recommend Osmosis. Osmosis does have some YouTube videos that are free, but if you want to purchase the entire thing and have access to all of their videos and their flashcards, I really recommend you going for Osmosis Prime. Also, I used Osmosis's flashcards. I basically just went through the OB-GYN section and just saved all their flashcards, and including medications. And then I studied those every day from day 1 to day 30. And to be honest, it really helped me out because you're reviewing that information over and over again. And like I've always said in my previous videos, repetition is the key for PA school because you're learning so much information. You want to make sure that you don't forget any of that. And specifically for your end of rotation exams, because for my program, we have our end of rotation exams on the last day usually. So can you imagine you're studying from day 1 and till day 30, you will forget information. But if you're going over that information over and over again every day, it'll be really fresh in your mind. And I learned this trick after suffering my first semester of PA school, which I struggled a lot. I started using this in second semester, and it really helped me out. Also, hopefully the studying tips are helpful for you guys. So basically, 5 weeks we had for our rotation. The first 2 weeks, first 3 weeks, I apologize, what I did is that I went through the information, I studied it. I was having to relearn things because I had taken like OB-GYN a while back. So I was having to relearn things, and that took me a while. And not only relearn things, I was having to learn new things that I was never taught during my OB-GYN module. And sometimes that happens when you're in PA school during your didactic year. You'll learn stuff during your clinical year, which they never taught you during your didactic year. So you're kind of like self-teaching yourself. And that's what happened. So during those first 3 weeks, I made sure I had everything down, whether it was with the pathophysiology or just the physiology. And then the last 2 weeks, I focused on solely questions. So I did a lot of practice questions. I really recommend Rosh Review. Rosh Review is great. They have a lot of practice questions. They have over 3,000. I think I've used 2,000 already. I have 1,000 left. But I mean, there's so many that you can reuse them and you keep forgetting them. So I really recommend Rosh Review. They have a lot of questions so you can practice, and it's really about testing yourself and see what are your weaknesses. And so Rosh Review is great. They even have EOR exams that are specific for the EOR you are taking. So they're like block exams. So I really recommend you to purchase, if you can, this bundle. So it's a bundle of your PANS Prep, your PANS exam questions, and then on top of that you also get your EOR bundle also. So I really recommend, if you can, to purchase it. I think I paid around 400 and something, and that was because I only got it through the discount with my class. So if you can, and you're a huge class, if it's more than 50 students, usually they'll give you about a 20 to 25% discount. So that's really good. So I really recommend Rosh Review for exam questions. I also use Exam Master because my program offers that. It's free for us, so I made sure I took advantage of it. And I also use Smarty Pants. So Smarty Pants has flashcards. They also have, if you don't like the physician assistant exam review textbook, I know some of my classmates don't like it, and for me, I have to say that for certain EORs I didn't like it because I felt like it had so much extra information that I didn't need to know for the EOR, and sometimes you're in certain rotations, your time is so valuable because the rotation is just so long. Like for example, for my surgery rotation, I was in there from 6 a.m. to 12 a.m. and that would be sometimes 3 or 4 days a week, and sometimes I didn't have time to study, and the days that I did have time to study, I was so exhausted. So I wanted to make sure I was just studying high yield things. And so sometimes the physician assistant exam review book did not have that high yield. It just had a lot of information, and I just thought it was very overwhelming. So for example, Smarty Pants, they have also end of rotation exam lessons for whatever EOR you're studying for, and they are also very high yield. So I really recommend them for that. And also they have a lot of exams for your EOR, so whether it's family medicine or internal medicine. So the more questions you do, the better. And then finally, UWorld. I really recommend UWorld. They have UWorld for PA students. My program actually ended up purchasing this for us so we could study, and I ended up using it. Those questions actually, I'll be honest, are a lot harder than the Rosh Review ones. It's like some of my classmates say, like Rosh Review is like papitas. It's really easy in comparison to UWorld, but it would definitely prepare you for your PANCE and then your EOR. I know I used it for my family medicine because rotation, my family medicine EOR, I was deathly afraid of that EOR because I kept hearing some of my classmates say that it was really hard and it was considered one of the harder EORs, and so I used that. And when I was going through the questions, I was very upset because I kept getting them wrong. I think I would get like out of 10, I would get like 8 wrong. So I was really upset. And then when I took the exam, I got a 91. And my professor was like, wow, how did you do that? And I said, UWorld really helped me out. Even though these questions are extremely hard and they're very like third level, like extreme critical thinking, they really prepared me for the EOR. Because when I took the EOR, I was like, wow, this is papitas. This is really easy. So yes, I really recommend UWorld. And that's what I did. So the last 2 weeks, and then whatever I kept seeing that I kept doing bad in, like for example, if I was studying for family medicine and my weakness was cardio, then I would go back and focus on cardio. So this is why questions are really good, because then you can see whatever you are lacking in. Alright guys, so that was just basically how I studied, and let's go get into it. So you're probably going to see me looking down a lot because I have my notes. Like I said, it's been a while. I'm recording this video in July, at the end of July. I had my OB-GYN EOR in November, so it's been a while since I've gone over OB-GYN, and some of the EORs that I've done, they do have a little bit of like OB-GYN, but not as much as your OB-GYN EOR. So first off, let's start into, you have to know the menstrual cycle. Make sure that you're familiar with the physiology of the menstrual cycle. Make sure that you know what day you're ovulating, what days you're menstruating, what hormones are involved. I had a lot of questions on this. What I did is that I did flashcards. I made sure I first watched videos, whether it was through osmosis. I really recommend osmosis. And I made sure that I understood the menstruation, and then I did flashcards so I can make sure that I am going over this information over and over again, because I know when I was in PA school, this was just really hard for me to understand. But make sure you know the menstrual cycle. So basically you have the ovarian and the uterine cycle. Normal tends to be about 20 to 35 days. Average, it's about 28 days in a woman. Days 1 through 5, you have menstruation, so about 5 days of bleeding, and then day 14 is when you have your ovulation. So days 1 through 14, the hormone that is involved is going to be, it's known as the follicular phase. And the days 14 to day 28, it's going to be the luteal phase. So make sure that you know that. That's high yield. It'll ask you what are days 1 through 14 known as. Just know it's a follicular phase. Days 14 to 28, it's going to be the luteal phase. So what day is the woman ovulating? It'll be day 14. And then from day 14 to day 28, it's a secretory phase in the uterine cycle. And then from day 1 to day 7, you have your menses, and then day 7 to day 14 is your proliferative phase, right? So you have the uterus, the proliferative phase, basically the wall of the endometrium is getting thicker. And then day 14 to day 28 secretory is when it tends to slough off. Okay. Also, another thing that I wanted to discuss is basically when is your corpus luteum happening? When does the corpus albicans happens? When does a follicle grow, right? So from day 0 to 14, that's when you have a growing follicle. A specific follicle is chosen during menstruation and it starts growing. And then you have the corpus luteum at day 14. And then if it is not penetrated by a sperm cell or it's not fertilized, and that's when it dies off and it turns into the corpus albicans. So make sure that you know that also. And then of course, in regards to the ovarian hormones, day 0 to day 14, you'll have your estradiol, right? And then day 14 to day 28 is when you have the progesterone that is more in abundance. I mean, you have both of them during day 14 to day 28, but your progesterone is the one that's more significant. So you might have a question with the patient asking you, and it'll ask you which one of these hormones is significant on day 15. Make sure that you say progesterone. I mean, you have both of them, but progesterone is found usually in higher levels. And then the luteinizing hormone, when is it highest? It's going to be on day 14, right? Okay, so let's go into amenorrhea. So amenorrhea is basically the lack of menstruation. It's when a patient is not menstruating. There's several causes of it. The primary cause is basically when a patient has not menstruated ever. So it'll be a young girl that's never had a menstruation whatsoever. And it's defined by several textbooks define it differently, but it'll be no menarche by the age of 13 without secondary sexual development, or no menarche by age 15 with secondary sexual characteristics. Okay, so what are secondary sexual characteristics? Your breasts, right, the pubic hair, etc. And I know the age tends to vary, like I said, in different textbooks, so just make sure that you are familiar with that. I know that, for example, for osmosis said that primary amenorrhea was characterized by no menarche by age 16 with secondary sexual characteristics, but if you see, it's within the same range. But I did see that definitely for no menarche by age 13 without secondary sexual development is primary. And then secondary, what is the secondary causes? So secondary is basically when the patient has already been menstruating. So it'll usually be an older female. And then for some reason they stop menstruating. And they have to be menstruating for at least 3 cycles for 6 consecutive months. So it can't be a patient that's only been stopped menstruating after 1 cycle or 2 cycles. It has to be at least 3 cycles for 6 consecutive months. So do not get trapped in that question. If it'll ask you and you read 2, it's not going to be secondary amenorrhea. It has to be, menses has to be absent for at least 3 cycles for 6 consecutive months. So what are the most common causes of secondary amenorrhea? This one you have to know for sure. The most common cause overall is going to be pregnancy, right? If a woman starts menstruating, you want to make sure that the patient's not pregnant. You want to rule that out before you start going deeper and seeing what other things are going on. And then also another cause of secondary amenorrhea is PCOS, so polycystic ovarian syndrome, and then when a woman, of course, has gotten into menopause. So going back into primary amenorrhea, what are some causes of it? There can be genetic causes like Turner syndrome, right? That's usually due to their chromosomes that they only have an X chromosome, right, and then O chromosome. Anatomical abnormalities, say they have an imperforated hymen. Polycystic ovarian syndrome, also hypopituitarism, Mullerian agenesis. Some of the signs and symptoms is that patient is basically going to have an abscess of menstruation, so the patient's not going to be menstruating. They'll have delayed secondary development, outflow obstruction if it's an imperforated hymen. How do you diagnose this? Of course, you're going to start with the beta HCG. For any woman that's not menstruating, you want to make sure that they're not pregnant, so you want to start with the beta HCG. You also want to look at their hormones, so their FSH and their LH, so the follicular stimulating hormone and their luteinizing hormone. It's going to tell you whether the patient is ovulating or not, and if there's something wrong with their hormones, and whether you need to replace them or not. You also want to do a karyotype analysis, right, to rule out things like Turner syndrome and Mullerian agenesis, and a pelvic ultrasound. So pelvic ultrasound is going to let you know that the patient has everything, that they have their ovaries, that they have their uterus, they have their fallopian tubes, because in Mullerian agenesis, the patient usually has no uterus. So you want to make sure all their organs are there. And also want to see if there's any masses, right, any tumors, any abnormalities, any cysts. So how is the treatment of primary amenorrhea? So you're gonna want to treat whatever is the underlying cause. If it's an imperforated hymen, then you're gonna have to go in there and treat it, right? Whether it's surgically done. Whether it is a patient that has polycystic ovarian syndrome, then you're going to go in there and treat that also. So it depends on the underlying cause. Some of the complications of amenorrhea, primary, is that the patient can suffer from infertility. So going back to secondary amenorrhea, the causes, once again, what's the most common cause? It's going to be pregnancy. It can also be hypothalamic. The patient can have a pituitary adenoma, PCOS, so polycystic ovarian syndrome. They're on oral contraceptive use. So that's another question that you want to ask them, whether they're taking any type of oral contraceptive use, because certain oral contraceptives, which we'll discuss in a few minutes, they do shorten a patient's menstrual cycle, or some patients even say that they don't have any menstrual cycle at all whatsoever. Whether they have Asherman syndrome, that's usually due to scarring, and then whether they have any eating disorders like anorexia. So signs and symptoms, they'll usually have an enlarged uterus. If the patient's pregnant, of course, you'll hear some fetal heart sounds. If the patient has a problem like polycystic ovarian syndrome, then the patient might be some overweight. And they might have some galactorrhea if they have a pituitary adenoma. So what is galactorrhea? That's when they're having discharge from the breast. It'll usually look like milk. And the patient's not pregnant. And also atrophic vagina, right? So in an older patient that is going into menopause. You also want to rule out your athletic triad. I had so many questions on this, so make sure that you're familiar with the athletic triad, which is a triad of amenorrhea, fatigue, energy deficiency, usually due to an eating disorder, and low bone mass osteoporosis. Once again, what is your athletic triad? Amenorrhea, fatigue, and energy deficiency, usually an eating disorder, and low bone mass or osteoporosis. So you'll have a question, and this patient will be presenting with all of these. Make sure that you know it is athletic triad. So what is going to be your diagnostic tools? So once again, you're going to do a beta HCG, right? You want to rule out pregnancy. You also want to do a TSH. You want to make sure that the patient is not having hypothyroidism. You want to do prolactin levels to rule out any type of adenoma the patient might be having. A progesterone challenge test to make sure that their hormones are working, that their progesterone and estrogen are working. And also, you can do an estrogen and progesterone challenge test, and then once again, an FSH and LH test also. So treatment, it's going to be the underlying cause, whether the patient is having any type of eating disorder, like anorexia, then you're going to make sure that the patient is eating. If it's polycystic ovarian syndrome, which is a patient that has multiple cysts in their ovaries, that's why it's called polycystic ovarian syndrome, then you want to give them oral contraceptives, because usually these patients have an imbalance in their hormones, and this will usually normalize our hormones. If the patient has Asherman syndrome, like I said, these are usually scars or lesions in the uterus, and you want to do skip lysis of the lesions. You want to go in there and get rid of the lesions, and you also want to do estrogen therapy. So real quick with estrogen and progesterone. So estrogen is usually known to increase the tissue in the uterus, and then progesterone will go in there and then slough it off. Okay. So now we're going to go into dysmenorrhea. So what is dysmenorrhea? Dysmenorrhea is painful menstruation. It's so painful that the patient can't live a normal life, or they can't resume their normal activities that they're accustomed to doing so. And this usually requires treatment. So there's once again a primary and secondary. Primary usually has no pathology. It's usually due to increased prostaglandins. It's usually found in younger patients, and they also can have increased leukotriene levels. Secondary is usually due to an organic cause. So endometriosis is one of the most common ones. You can also have adenomyosis, which is similar to endometriosis. It's just location of the uterus. You also can have pelvic inflammatory disease, cervical stenosis, leiomyomas, and polyps, adhesions, and this tends to be found in the older patients. Okay, so make sure that you know the difference. So primary, it's found in the younger patients. Secondary, it's found in the older patients. And that's the same thing that we saw in amenorrhea, right? Amenorrhea was found in younger patients that have never had a menstruation before, and then secondary amenorrhea is found in older patients. So what are some of the symptoms of this? It's going to be cramps, lower abdominal pain, that usually radiates to the back and then usually to the groin area or to the legs. They'll have a headache, nausea, and vomiting because this pain is so much. It'll be cyclic, so it comes and goes, and then when it comes, it's extremely severe. And this tends to occur just before their menstruation. And it's so painful that the patient cannot attend school or work. Usually you'll see that in the stem of a question, is a patient having this abdominal pain, this extreme cramping that they just cannot attend work or school. And this is when you tell yourself, I have to treat this. Fatigue, malaise, and the patient will have also a normal physical exam. So you will do your abdominal exam and you won't feel any lumps or anything abnormal. Diagnosis is going to be clinical. You want to rule out any secondary underlying condition that can be causing this dysmenorrhea. And you're going to do also a pelvic ultrasound, right? Because you want to rule out things like endometriosis or fibroids, also known as leiomyomas. And then, how are you going to treat this? So you're going to treat this primarily with NSAIDs, because what do NSAIDs do? There are antiprostaglandins, and what is usually dysmenorrhea due to it is that the patient has increased prostaglandins. So NSAIDs will help decrease the prostaglandins. You could do something like ibuprofen or naproxen. And you tell the patient to start this 1 to 2 hours before their menses. You can also tell the patient to apply some heat, exercise, and then you can also give them some oral contraceptives. So next one, we're going to go into dysfunctional uterine bleeding. Okay. It's usually due to non-pathological causes. So if a patient is complaining of bleeding that is happening abnormally during their menstruation, and you've ruled out everything else, then that's when you would diagnose it as dysfunctional uterine bleeding. Okay? And the patient will have abnormal menstrual bleeding, whether it's the duration, their quantity, frequency. So some of the causes is that sometimes the medication that the patient's taking, whether they have coagulation disorders, whether they have polyps, fibroids, some type of malignancy, endometrial and ovarian dysfunction, or even genital infection. Signs and symptoms, so it's going to be abnormal bleeding. They might be passing clots. They might have some heavy flow, or even just spotting in between their periods. And symptoms of anemia if the patient's been bleeding a lot more than 7 days. So how are you going to diagnose this? Once again, you're going to do a beta HCG just to rule out the patient is not pregnant. You're going to do a CBC. You're going to see whether they're anemic or not. So what's the most common type of anemia found in a patient that is menstruating? It's going to be iron deficiency anemia, right? So you want to make sure that you want to rule this out. These patients can become anemic if they're losing a lot of blood. You want to do a pelvic ultrasound or transvaginal ultrasound, and then an endometrial biopsy if a woman is greater than 45, because you want to rule out things like endometrial cancer. One quick pearl, which we'll go over, but I'll mention it now, is that if there's a patient that is postmenopausal and they're bleeding, first thing that you want to rule out is endometrial cancer. Usually this is a sign of endometrial cancer because women that are postmenopausal usually not bleed, correct? You can also do oral contraceptives for dysfunctional uterine bleeding, or you can give them a monthly progesterone or an IUD. And you can also do DNC, but this is not first line. So if you do need to do surgical treatment, then you can do endometrial ablation, myomectomy, for example, if the patient wants to have children in the future, or a hysterectomy if the patient doesn't want to have children in the future. So hysterectomy, you get rid of everything, and myomectomy is that you just get rid of the tissue in the endometrium. This helps the patient have children in the future if they want to have children. If it's acute and severe bleeding, you'll have a question on this. You want to make sure that you're paying attention to the hemoglobin level, okay? If it's usually less than 10, like I've seen some hemoglobin levels of 9 or 8, then that's when you want to consider something like a high dose IV estrogen, okay? So make sure that you are familiar with that. So if it's acute or severe bleeding, high dose IV estrogen, you'll see that definitely. If it's very severe, you can also use something like a GnRH agonist. Okay. And then I wanted to go into discuss the abnormal uterine bleeding. So the types, make sure that you are very familiar with this. I had a lot of questions and I kept getting these messed up. And I think I still do to this day get them messed up. And so I made sure that I went over flashcards to ensure that I knew the differences between them. Oligomenorrhea. Oligomenorrhea is a cycle that is greater than 35 days. So a patient complaining of menstruation More than 35 days, it's going to be oligomenorrhea. Polymenorrhea is a cycle length that is less than 21 days. Hypomenorrhea is scanty menstruation. Amenorrhea, absence of menstruation for 6 months. Menorrhagia is that the patient's having regular cycles, but they have excessive flow. So they're bleeding a lot during their cycle. You know, usually a woman will usually bleed a lot the first few days and then it'll decrease throughout the days. But this patient is bleeding a lot throughout the 7 days that they're having the period, or 8 days, depending on the length of the menstruation. And then you have metrorrhagia, which is irregular cycles. So the patient can have a period 1 month, and then they'll skip 2 months, and then they'll get a period the 3rd month. Or they can have a period the 1st month, and then they'll have a period again 2 weeks later. So it's very irregular. And then you have menometrorrhagia, which is basically menorrhagia and metrorrhagia together. Is the patient is going to have both irregular cycles, excessive flow, and duration. I always messed up the menorrhagia and metrorrhagia. So menorrhagia is excessive flow. Metrorrhagia is irregular cycles. Okay, so let's go into premenstrual syndrome. You'll definitely see this on your exam. You'll also see it in your psych EOR, so be familiar with this one. It's very common in women in the ages of 20 to 30, but very rare in adolescents. Some of the signs and symptoms the patient will have is that they'll have irritability, mood swings, depression, anxiety, bloating, breast tenderness, insomnia, fatigue, hot flashes, appetite changes, confusion, poor concentration, headache, pelvic pain, tension, dysphoria. And these symptoms have to occur in the second half of their menstrual cycle, specifically the luteal phase. So make sure you know that. I had a question that asked you, basically, it gave you the symptoms of this woman that was having all these symptoms of premenstrual syndrome, and then it asked you, when does this occur? And you need to know that it occurs, and it must occur during the luteal phase, okay? Luteal phase for premenstrual syndrome. So it's going to occur in the second half of the menstrual cycle. It must occur. So how do you diagnose this? This patient's going to be symptom-free for the 7 days in the first half cycle. And usually you can tell the patient to have a diary of their symptoms, because you want to make sure that they occur at least for 2 consecutive cycles. And symptoms tend to improve with menses. So once they have their menstruation, these symptoms will go away. So symptoms improve with menses. Treatment. So if it's mild, you tell the patient just to do something that is like diet, exercise. Tell them to avoid coffee if they drink a lot of coffee, avoid tobacco, alcohol, eat small frequent meals. So that's going to be your first line if it's something that's mild. So make sure that you're familiar with that. You'll have a question and it'll ask you what is the best line treatment for this patient because it's something mild. Then you would choose something like diet and exercise. If it's moderate to severe, you'll have a question like this also. So basically a patient that just cannot function anymore because she's having these premenstrual symptoms and it's just so bad that it's affecting her work, it's affecting her daily life, it's affecting her relationship with her husband, and they've tried exercising and dieting and it's not going away, then you would consider that as something as moderate or severe, and you would consider pharmacotherapy, right? You would do SSRIs like fluoxetine. Even you can do an SNRI like venlafaxine, but definitely go with your first SSRIs like fluoxetine or sertraline. You can also do ovulation suppression with oral contraceptives like yasmin, spironolactone, calcium carbonate, and then a low sodium diet to help with bloating. But make sure that you know that SSRIs are usually used for moderate severe or oral contraceptives. So premenstrual dysphoric disorder, what is that? Premenstrual dysphoric disorder is basically happens during premenstrual, so luteal phase of the cycle, and symptoms stop at start of menses or during menses. What is this patient going to be complaining of? So in premenstrual dysphoric syndrome, the patient is going to be complaining of dysphoria, irritability, anger, depression, anxiety, and hedonia. Basically, they don't want to do anything. Problems concentrating, appetite changes, food cravings, hypersomnia or insomnia. They feel overwhelmed and they're out of control. Breast tenderness, swelling, joint or muscle pain, bloating, and weight gain. What ages is this most commonly found in? And once again, it's similar to premenstrual syndrome. It's going to be found in ages of 20 to 30, but most commonly occurs 2 weeks before menses and goes away with menses. So it's basically severe premenstrual syndrome. So you have your premenstrual syndrome, and then you have your premenstrual dysphoric disorder, which is severe premenstrual syndrome. So what we discussed earlier, but a lot worse. And if you notice, this also occurs before menses and goes away with menses. Diagnosis, basically the patient has to have more than 5 of the symptoms that I discussed. So they have to have more than 5. So they have to have dysphoria, irritability, for example, anger, depression, anxiety, more than 5 of these. And these symptoms will improve during menses. And this is usually going to be confirmed, once again, similar to what we discussed in premenstrual syndrome, with these symptoms going on for at least more than 2 cycles. And these symptoms are so bad that they will affect the patient's professional or personal life. Treatment is that, once again, first line is going to be lifestyle measures, right? You're going to tell them to exercise, change their diet. And if symptoms tend to be present all month, it's less likely to be premenstrual dysphoric disorder, right? Because these symptoms are only going to be present during or before their menstruation. But if these symptoms are throughout the entire month, then maybe you want to think about maybe the patient might be having depression, okay? If it's moderate and severe, similar to premenstrual syndrome, you're going to do SSRIs, oral contraceptives, GnRH agonists, and then if the patient has tried everything, say they tried exercise, the first line treatment, change their diet, you put them on oral contraceptives, SSRIs, and you're still having this, then you can consider surgery like a bilateral oophorectomy, they get rid of the ovaries, or with hysterectomy, so the entire ovaries, uterus, everything. Okay, so now we're going to go into menopause. Make sure you are also very familiar with menopause. I had so many questions on menopause. So with menopause, basically it's a permanent cessation of menstruation at the end of reproductive cycle due to loss of ovarian follicular activity. So basically your oocytes are depleted. That's why the woman is not menstruating anymore. Etiology. So the average age of menopause in women is 51, but like I said, this tends to change in whatever textbook you're reading. And it tends to range between the ages of 45 to 55 years old. So basically in the ovaries, they have no eggs, no follicles, and they lack estrogen. If it is premature menopause, then it'll be a patient that started menopause at age 40 or even less. And it's usually due to natural or induced causes. So for example, if a patient has a family history of their mother going into menopause at age 40 or less than 40, then that can be also due to it. Or if a patient had a hysterectomy, for example, then that can be a cause of why the patient is not menstruating anymore. And then you have delayed menopause, which is beyond 55 years. So basically, a patient will not have a menstruation for 12 months, okay? This is what defines menopause, so make sure that you know that. So amenorrhea for 12 months. If they've only had amenorrhea for 6 months, it's not considered menopause. If they've had amenorrhea, so lack of menstruation, for 12 months or longer than 12 months, then you can consider it menopause. So what are the signs and symptoms? Once again, it's going to be your abrupt cessation of menstruation. They'll have gradual decrease in amount and duration, so they'll spot here and there, and then it'll definitely go away. They might have irregular menses. Definitely know this. They'll have hot flashes, sleep disturbances, weight gain, low libido, headache, mood changes, hair loss, brittle nails, and vaginal dryness. Usually you'll also read at the patient on a physical exam or vaginal exam, they'll have an atrophic vagina. And this is usually due because they're not creating estrogen anymore, so they have a decrease in estrogen. So diagnosis, this one you have to know, they're going to have an elevated FSH level, so elevated follicular stimulating hormone, okay? It'll be between 21 to 100, and they'll also have elevated luteinizing hormone. So they'll have both elevated FSH and elevated LH, but they'll have decreased estrogen and estradiol levels. These patients that are are at increased risk of cardiovascular disease and osteoporosis because they're not creating estrogen like they used to be when they were pre-menopausal. So you want to make sure that you check their lipids, okay, to rule out any cardiovascular disease. And you want to make sure that you check their glucose and do a DEXA scan to rule out osteoporosis. So what is a treatment? So you can give them hormone replacement therapy, whether it's estrogen or estrogen progestin. Usually women that are healthy, greater than 60 years old, with no contraindications, you can do this, okay? And what are some of the benefits of this is that it relieves their menopausal symptoms, it decreases their risk of cardiovascular disease and stroke, it decreases osteoporosis, and decreases dementia. What are some of the risks for hormonal replacement therapy? And make sure that you are very familiar with this. So hormonal replacement therapy is good in women, postmenopausal women, but you want to make sure that you're careful because it can cause endometrial cancer, right? It can cause usually a growth of the endometrium tissue or the layer, and this usually causes abnormalities, and this can make them more prone to having cancer. So that's why you want to be careful with hormonal replacement therapy in older women, especially postmenopausal women. Other risks are breast cancer, pulmonary embolism, breast pain, and usually hormonal replacement therapy is contraindicated in patients that have a DVT, right? Pulmonary embolism, because hormonal treatment or oral contraceptives are known to cause, or they can make a patient hypercoagulable, so it can make them more prone to getting a deep vein thrombosis, pulmonary embolisms. Patients that have high risk for breast cancer, if the patients complain of breast pain, if the patient has liver disease, then you want to make sure that you are not giving hormonal replacement therapy in these patients. These are contraindicated. So for hot flashes, you'll have patients on a question stem that will be complaining of hot flashes. Make sure that you want to do first line treatment would be something like exercise. Tell them to pace their respirations, use relaxing activities. Tell them to avoid triggers, whether it's spicy foods, hot drinks, caffeine, alcohol, high fat. You can also give them sleep medications because some of these patients can have trouble sleeping. Hormone replacement therapy, if the patient is a candidate for it. You can also give them SSRIs. SSRIs was one of the huge ones I kept giving them. So what is a good SNRI for hot flashes in women, especially postmenopausal? It's going to be venlafaxine. So make sure that you know that. It might ask you a question and you're looking for an SSRI and it's not on there, but you see it in SNRI, venlafaxine, definitely. You can also give them gabapentin, clonidine. And for their mood changes, so their mood swings, you can give them something like an SSRI or SNRI. And for their atrophic vagina, you can give them some over-the-counter lubricants or vaginal estrogen cream. Okay. So now we are going to go, I'm just going to go into real quick talking about some of the things that you need to know for menopause. So what are hot flashes? Basically, hot flashes tend to be worsened by eating. The patient's going to feel extremely warm when they're exerting themselves, or if they're stressed, or if they're drinking alcohol. Some of the GU symptoms a patient might have that is going into menopause is that they have vaginal atrophy. So the vagina is going to be very dry. The patient's going to be complaining of itchiness, so pruritus, and dyspareunia is a huge one. So they'll have pain whenever they are having sexual intercourse. So be familiar. If you have a patient that is having all these symptoms in a question stem, then think about menopause as a differential diagnosis. They can also have urethral atrophy, which can lead to stress incontinence, frequency, urgency, and painful urination or dysuria. They can also have mood changes, so irritability, anxiety, depression, sleep disturbance, and their hormones. Like I said, it's going to be low estrogen and elevated FSH specifically, and then also elevated LH. The patient can also have fluid retention, so they'll have breast tenderness, extremity edema, waking, a lot of bloating. In regards to autonomic symptoms, they'll have heart pounding, confusion, dizziness, insomnia, fatigue, because their body's changing. Their hormones are wacky. They're all over the place. The patient can also have musculoskeletal symptoms like muscle aches, joint aches, headaches, cramps, emotional symptoms like they can be having nervous tension, mood swings, definitely. A lot of these women have depression, irritability, anxiety, crying. Okay, guys, so let's move on to some of the famous STDs, okay? So infections that you'll see. You'll definitely see a lot of these also. So you want to make sure that you know how to treat them and how to diagnose them. So I know it's important to know how they present, and you'll be able to, you're like, this is what it is, but you also want to know how to diagnose them. So what are the best diagnostic tools and how to treat them. So let's start with chlamydia. Chlamydia is a very, very, very common one. I saw a lot of these during clinic when I was in clinic. So usually it's an infection of the cervix, and all women under the age of 25 should get a test annually. And usually chlamydia is co-infected with gonorrhea. So chlamydia trachomatis is a gram-negative bacteria. So sometimes they'll describe the bacteria to you, so make sure that you know how it looks. It's the most common STD in the US, usually due to patients that are using unprotected intercourse. It can lead to pelvic inflammatory disease, so very common in younger patients. Signs and symptoms, usually the patient's going to be asymptomatic, the most common symptoms, but of course on the question stem you'll see a patient that's symptomatic. So what are the symptoms that they're going to have? They're going to have yellow mucopurulent, that is a huge high yield, it'll say mucopurulent discharge, and a friable cervix, so a very inflamed, reddened cervix. They may complain of postcoital bleeding, abnormal bleeding, and then painful urination. But make sure that you know that they will have a friable cervix and yellow mucopurulent discharge. How do you diagnose it? You're going to do it with an NAAT exam. It's basically a cervical swab. You can do an ELISA or PCR with urine or an endocervical culture, but make sure that you know it's an NAAT. How do you treat it? You're going to treat it with azithromycin or doxycycline. This is first line, and you're going to treat both the patient and the partner. You also want to make sure that you test for gonorrhea, but you don't necessarily have to treat it, okay? If the patient is pregnant and they're symptomatic, then you're going to treat these patients with penicillin or cephalosporins. You definitely do not want to give a patient that's pregnant tetracycline like doxycycline, right? So in these patients that are pregnant, you're going to give them penicillin or a cephalosporin. So some of the complications of chlamydia, you might have a question on this also, is pelvic inflammatory disease. So basically the infection migrates up the vagina. It can infect other parts of the woman's, it infects the ovaries, etc. Also Fitz-Hughes syndrome, which is those adhesions that you see on the liver. It can cause Reiter's syndrome, so it can become systemic. Trachoma conjunctivitis, okay, so it can go in the eye. This is something that's very common in newborns whose mothers had chlamydia, and these patients are born vaginally. And then premature labor if the patient is pregnant with and they have chlamydia. But the big one for sure is pelvic inflammatory disease. Next one, this one's very rare. I think I had only one question on this one. Lymphogranuloma venereum. So it's an STD, and it's associated with chlamydia trachomatis. So chlamydia has, of course, different types, and it is associated with chlamydia trachomatis, and it's primarily an infection of the lymph nodes. So usually a patient will be sexually active. They'll be having unprotected intercourse, found in younger patients. How is the patient going to present? They'll have a painless genital ulcer on the vaginal wall, genital ulceration, buboes formation. Basically, these buboes are going to be painful. It's going to be your inguinal adenopathy. And how are you going to diagnose this? PCR and serology, and you're going to treat this the same way that you would treat a patient with chlamydia, right? Because the primary cause of this is chlamydia. You're going to treat them with azithromycin or doxycycline, and you're going to IND the buboes and make sure that you treat their partners also. So this can actually, as you can see, it presents very similar to syphilis, right? But in these patients that they'll have a painless genital ulcer on the vaginal wall, for example, for women, genital ulceration, and they'll have buboes formation. And these buboes are going to be very, very painful. Gonorrhea. Gonorrhea, as we said, is very commonly co-infected with chlamydia. It's an infection of the cervix, and this one can also lead to pelvic inflammatory disease and infertility. So gonorrhea is due to what bacterial infection? It's due to Neisseria gonorrhea. This is a gram-negative diplococcus. Make sure you know that gram-negative Diplococcus, because usually it'll give you the description of the bacteria, like I said, and you have to make sure that you know that it's gonorrhea. It's the second most common STD in the US. Signs and symptoms. The patient can be asymptomatic, or they might have mild symptoms. They'll have malodorous discharge. And usually with this one, it'll say purulent discharge versus your chlamydia, it's mucopurulent discharge. This one is purulent discharge, it's malodorous, cervical motion tenderness, and painful urination. You're going to diagnose this with an ELISA or DNA test. You can also do an NAAT test or a gram stain. You're going to treat this with intramuscular ceftriaxone, but you also have to treat for chlamydia. So with chlamydia, you don't necessarily have to treat for gonorrhea, but with gonorrhea, you have to treat for chlamydia because chlamydia is the most common STD found in the US. And usually chlamydia and gonorrhea are buddy-buddy, right? So you're going to treat them with intramuscular ceftriaxone. You can do that in clinic, also known as Rocephin, right? And then you're going to treat the chlamydia with either azithromycin 1 gram or doxycycline. There are a way that you can decide which one you want to give is whether you see if the patient's going to be compliant with medication or not, okay? Okay, so next one's going to be herpes, okay? Herpes is very, very contagious. The patient can actually be asymptomatic and still be very infectious, and they can be shedding the virus in fluid. So the first outbreak is going to be the worst one, and then after that, they're not as bad as the first one. And herpes, genital herpes, very common in, of course, sexually active adults. So how is the patient going to present? They're going to have localized tingling and burning 2 to 5 days post-exposure. They'll have lesions. They'll have these red pustular painful vesicles. So usually whenever you read anything that's related with herpes, it'll be described as a vesicle. And they're going to be painful. They might also have some lymphadenopathy. You're going to diagnose this, of course, with a clinical, or you can do a PCR assay for the herpes simplex virus DNA, which is a preferred test. But what is the gold standard? The gold standard is going to be a Zank smear. So you can do viral cultures. Okay? So if the question asks you what is a gold standard, I had several questions about this. I don't remember whether it was on the EOR or on the questions that practice questions that I was taking. Gold standard is going to be a Zank smear. So you're going to do a Zank smear, viral cultures. If not, it's usually a clinical diagnosis, and you can do a PCR assay for the herpes simplex virus DNA. Treatment, it's going to be sitz baths. You can also give them some analgesics. If it's a primary infection, you can reduce their viral load, right, by giving them something like acyclovir. If you want to suppress the virus, then you can give them something like valcyclovir. If it's episodic, acyclovir. So usually you're going to give them acyclovir. It's an antiviral. If the patient's pregnant, they have a 50% chance of transmitting this to their newborn. So of course, if the patient has active herpes in the vaginal area, you want to make sure that with these women that you do a C-section. HPV. So HPV is usually infected with contact with the infected genital skin, mucous membranes, and bodily fluids. So make sure that you know the strains, okay? Which ones are low risk? Low risk are HPV 6 and 11. So once again, low risk HPV 6 and 11, make sure that you know this. What are high-risk strains? So you have 16, 18, 16 and 18. Make sure that you know those. And then the other ones, also 31 and 45. With these, you have increased risk of cervical cancer. So once again, high-risk 16 and 18, low-risk 6 and 11. These are the human papillomavirus strains. How is the patient going to present? They'll have these tiny, painless, soft, fleshy lesions. Warts that have a raised papillomatous or spiked surface. Basically, it'll be described as a cauliflower-like lesion. So look for that in your question stems. Diagnosis, it's usually a clinical diagnosis. You can do a biopsy, but that's kind of painful in patients, right? So it's usually a clinical diagnosis, but biopsy is definitive. But the gold standard is going to be a PCR for the human papillomavirus DNA. And then, so treatment, you're going to do podophyllin, you can do trichloroacetic acid, you can also do cryosurgery, electrosurgery, excision, laser ablation, podophyllic or imiquimod. And prevention, it's going to be Gardasil, right? It's going to be the vaccine. Okay? And usually this vaccine is given in women from ages 11 to 26, and it's usually 2 to 3 doses over 6 months. Okay, so once again, the treatment for this is usually, it's very painful, so you can give patients things like a podophyllin if the patient just doesn't want it anymore there because it's something that is cosmetic, then you can consider something like cryosurgery or electrosurgery. So now we're going to go into pelvic inflammatory disease. Basically, it's when an infection, like a bacteria, ascends to the upper genital tract. It infects the uterus, the fallopian tubes, and the ovaries. So this is why it's really important that these women get treated for these infections, because you want to prevent things like pelvic inflammatory disease, which can scar and usually can leave a woman infertile. So what are the most common causes of PID? It's going to be gonorrhea and chlamydia in sexually active women. Usually in the question stem, you'll have a young woman, age 15 to 29. The patient will be having a very risky behavior, so they have a lot of sexual partners. Sometimes they'll have a history of an IUD. Signs and symptoms, it's usually most common during and around menses. So usually have some low abdominal pain, pelvic pain, back pain. They'll have purulent discharge. They'll have some pain with deep dyspareunia, so they'll be complaining of pain during sexual intercourse, specifically if it's deep. They have these symptoms of nausea and vomiting. Fever is a big one. So if you have a patient that has fever, chills, then that's when you're probably considering PID, okay? And they have back pain. Diagnosis, the patient has to have all of these three. They have to have abdominal tenderness, adnexal tenderness, and cervical motion tenderness, also known as your chandelier sign. Once again, they have to have all three of these: abdominal tenderness, adnexal tenderness, cervical motion tenderness, also known as a chandelier sign. So how are you going to diagnose this? You're going to diagnose this with a transvaginal ultrasound. And what you'll see is that you'll see like these thickened tubes. You'll see some like free fluid. You might seem to see some tubo-ovarian abscesses in like the severe cases. And they have to have at least one of these. They either have to have a positive gram stain of pus, a temperature greater than 38 degrees Celsius, so they have to have a fever, a white blood cell count more than 10,000, and you have to find pus on the choledocentesis or the laparoscopy, or an abscess for you to be able to diagnose pelvic inflammatory disease. Treatment is you're going to treat whether the patient is inpatient and they need to be admitted. You're going to treat them with cefoxitin or cefotein plus doxycycline, or you can give them clindamycin and gentamicin. If the patient's outpatient, then you can give them ceftriaxone plus doxycycline or metronidazole, and you're going to hospitalize them if the patient is not improving in 3 days. You want to make sure that you're treating pelvic inflammatory disease aggressively, because like I said, it can lead to a lot of things. It can lead to ectopic pregnancies if the patient's pregnant. They can also lead to pelvic adhesions. So now we're going to go into syphilis. So usually syphilis is due to what? Treponema pallidum. That's going to be the bacteria that is causing this infection. It's usually transmitted by sexual contact, so contact with lesion, mucous membranes. Patient's going to be complaining of a painless single red round firm ulcer. So it's going to be a canker, okay? And usually there's primary, secondary, and tertiary symptoms. So secondary, they're going to have a macular papular rash. So they'll have a rash on their palms, on their soles of their feet. And they might have fever, lymphadenopathy, headache, arthritis, meningitis, hepatitis. So it's, as you can see, this bacteria already has become systemic. And then you have tertiary, which happens a long time. So if you read the history of syphilis, it's really, really interesting. A lot of immigrants suffered from this, and you would see a lot of the tertiary infections where it's been like about 1 to 20 years after they've had the infection, and they have gamma, cardiovascular iritis, neurosyphilis. Okay, they can have that Arjo-Robertson people. Screening, how are you going to diagnose this? You're going to diagnose this with RPR, VDRL, titers, so make sure you know how to diagnose this. Make sure that you know that the infection that's causing this is Treponema pallidum, okay? And you're going to confirm with an FTA-ABS. It's also known as a fluorescent treponemal antibody absorption test, so make sure that you know that. You can also confirm with MHA-TP. And how are you going to treat this? You're going to treat this with penicillin, okay? Interestingly, penicillin is really good for treating this syphilis. So penicillin, it's usually penicillin, benzathine penicillin G. You're just going to give them 1 shot. If they are allergic to penicillin, then you can give doxycycline, and you want to make sure that you're following up with this patient at least at 6 and 12 months. So once again, screening, you can do an RPR or VDRL titers, and you're going to confirm with the fluorescent troponemal antibody absorption. It can say that, or it can say FTA-ABS on your answer choices. So now we're going to go into cancroids. Most common cause of cancroids are going to be Haemophilus ducreyi. It's very common in African Caribbean. So with these patients, you'll have a patient that it'll say in the question stem that traveled from Africa. It's more common in males. And patients going to be complaining of a painful, demarcated, non-indurated ulcer in the anal genital region. And they'll also have some inguinal lymphadenopathy, soft and rugged edges. Make sure that you don't confuse this with syphilis. So with cancroids, it's going to be a painful ulcer. With syphilis, it's going to be a painless ulcer, okay? So if you're reading the question stem and it sounds like syphilis, and then you read and it says that the ulcer is painful, then it's going to be a cancroid, okay? Because these patients are also going to have the inguinal lymphadenopathy. How are you going to diagnose this? You do a culture swab, okay? Typically is the diagnosis, but sometimes it's really difficult to culture Haemophilus ducreyi. How are you going to treat this? You're going to treat this with azithromycin. You can also do ceftriaxone, rocephin, or erythromycin. Now we're going to go into candidiasis. Okay, so candidiasis vaginosis. This is not a sexually transmitted disease, and it's commonly found in premenopausal women. Most common one is Candida albicans, but you also have Candida glabrata, Candida tropicalis, but the most common one is Candida albicans. Risk factors for candidiasis is usually a woman that's pregnant, right? A patient that is diabetic because they are immunocompromised, a patient that's obese, patient that is immunosuppressed, oral contraceptives, if they're on corticosteroids, because corticosteroids can make them immunosuppressed, if they're taking antibiotic therapy, if the patient has a warm and moist vaginal environment. So these are some of the risk factors. Signs and symptoms, how it's going to be described is that you'll see a white clumpy discharge. It's itchy, it's burning. You'll have some painful urination, painful sexual intercourse. And then on physical exam, you'll see that bright red inflamed vagina. You'll see excoriation and then a cottage cheese discharge. So how are you going to diagnose this? It's going to be the whiff test. Usually the whiff test is usually negative, but you can also do a KOH prep or saline wet prep also. You'll see some filaments and spores. So that's how it will usually be described on the question stem, is that you have this patient with these symptoms and then they saw some filaments and spores or some budding yeast, and then that's when you know it's candidiasis. The pH, make sure that you know the pH of this, because that's how you want to make sure that you can differentiate between candidiasis, bacterial vaginosis, and trichomonas. The pH for this one is going to be lower, okay? Versus in bacterial vaginosis, your pH is going to be more than 4.5. In your trichomonas, your pH is going to be usually more than 5. In vaginal candidiasis, your pH is going to be between 4.0 and 4.5. So this one is going to have a low pH. Make sure you know that candidiasis, low pH. The gold standard diagnosis for candidiasis is going to be a positive yeast culture of vaginal secretions. If it's complicated, then you want to confirm with a microscopy and culture. Treatment, you're going to give a topical intravaginal agent, so any of the azoles, or like for example, miconazole cream for 3 days. Or if the patient prefers something orally, like you only take it once, you can do something like diflucan. If it's complicated, then or systemic, then you can give something like fluconazole for 6 months. Any of the azoles, any of the antifungals you can give. So now we're going to go into bacterial vaginosis. Once again, this is also not STD or not transmitted sexually. It's basically due to the alteration of the normal vaginal bacterial flora. So the patient's going to usually have a loss of hydrogen peroxide that produces lactobacilli and overgrowth of anaerobes. So make sure that you know this, the pathophysiology. Basically, loss of hydrogen peroxide producing lactobacilli and overgrowth of anaerobes. So lactobacilli helps you, and it's a good bacteria. And if you don't have this, then you're more prone to getting bacterial infections, right? Because you have this overgrowth of this bad bacteria. So it's found in all ages. The most common cause is going to be Gardnerella vaginalis, okay? So make sure that you know that. Sometimes patients that have multiple sexual partners, they're more prone to get this, but it's not related to STD. Also, patients that are currently on an antibiotic, right, because the antibiotic will deplete all your good bacteria, and if it depletes all your good vaginal flora, then you're more prone to getting a bad bacteria infection like bacterial vaginosis. And also if a patient has an IUD. Signs and symptoms, it's going to be a fishy, right, a fishy vaginal discharge. It's going to be a milky, homogeneous, malodorous, non-irritating, non-painful discharge. It's usually going to be described as a off-white or the thin gray discharge. So diagnosis, it's going to be your Amsel's criteria. They need to have more than 3 out of the 4 that I'm going to talk about right now. So they have to have a gray and thin vaginal secretion, more than 20% of clue cells. This one's huge. Pathognomonic for bacterial vaginosis is clue cells on microscopy. Their pH is going to be more than 4.5, so it's going to be more alkaline in comparison to your candidiasis, right, which was more acidic. They'll have this fishy amine odor with a KOH prep, so they're going to have a positive whiff test. This is one of the ones going to have a positive whiff test. So once again, you have to have at least 3 out of the 4 ones to have diagnose bacterial vaginosis. And you can also diagnose it with a wet mount or a pelvic exam. So clue cells you'll see gray vaginal secretions, thin gray vaginal secretions. Their pH is going to be greater than 4.5, and it's going to be a fishy odor with a positive whiff test. So let's go into Trichomonas vaginosis. This one is a sexually transmitted disease, and it's transmitted by a parasite. It's a flagellated parasite. These are really cool to see under the microscope. They look like little kites, literally, or little hearts. Actually, it was one of my favorite of my sisters when we were taking our parasitology class to look under the microscope because they're so pretty. And some of the signs and symptoms the patient's going to be complaining of is they're going to have this green, yellow, frothy discharge. That's pathognomonic for trich. So whenever I read something that said green, yellow, frothy discharge, and then they have this punctuate erythema or a strawberry cervix, because it literally looks like strawberry. It's red, and then you have like white around it, white little dots, then it's trichomonas. The patient's also going to be complaining of odor, itching, burning, abdominal pain, dysuria, painful sexual intercourse, so dyspareunia. I had a case of this in my ER rotation, and it was a woman, and we thought she had something related with her abdomen, because she was complaining of abdominal pain, severe abdominal pain. She was complaining of nausea. We asked her if she had any vaginal discharge. She said no, but of course she was probably embarrassed to say that. And so we did an ultrasound, like a transabdominal ultrasound. We didn't find anything. We did a CT scan. We didn't find anything. So my doctor was like, I don't know what to do. And then he was like, you know what, it might be something related to in the vaginal area. So maybe she might have meant she was complaining of pelvic pain. So yes, we went in there and we did a pelvic exam, and she ended up having trichomonas. So it was definitely the color it was described. It was a green frothy discharge. It's malodorous, very malodorous. And she did have that like inflamed erythema cervix. So with this one, like I said, it's usually due to women that have like multiple sexual partners. They might have history of other sexually transmitted infections. When you're taking a history, usually it's patients between the age of 20 to 45 years. And then on diagnosis, they're going to have a positive whiff test. Their pH is going to be higher, so it's going to be more than 5.0. So as we discussed, candidiasis has a pH that's less than 4.5, right? Bacterial vaginosis has a pH that's greater than 4.5, and then trichomonas has a pH that's greater than 5.0. You're also going to do a microscopy, which is the best test, and this is where you're going to see the parasites, right? It's motile trichomonads, and you can see them. They look like little kites, and they're swimming around. And they also have increased leukocytes. Drug of choice for this is going to be metronidazole. So just give them metronidazole, make sure that you treat them, and then you treat the partner. So now we're going to go into atrophic vaginosis. It's commonly found in women that are postmenopausal because due to lack of estrogen, right? They're not creating estrogen like they used to. So a patient's going to be complaining of dryness, itching, burning, painful sexual intercourse, pelvic pressure. They might have some discharge, thinning of the vaginal epithelium. You'll see loss of rugae on the vaginal exam, and then cervical friability. Diagnosis, it'll be pH is greater than 5.0, decreased superficial cells. They might have some white blood cells. And then treatment's going to be vaginal or oral estrogen. Okay, so once again, candidiasis, we're going to see pseudohyphae on the wet mount. Trichomonas, we'll see a flagellated parasite. Okay, it'll have an undulating membrane. And then bacterial vaginosis, it's usually the clue cells that you'll see on the web mount. For the amine odor with your KOH, you'll see that it's going to be positive in both bacterial vaginosis and trichomonas, but it's going to be negative in your candidiasis. And then remember, we discussed the pH, so less than 4.5, it's going to be candidiasis, more than 5, it's going to be trichomonas, and more than 4.5, it's going to be bacterial vaginosis. In regards to the color, on candidiasis, it's going to be a white, right? It's going to be thick discharge. And then for trichomonas, it's going to be a yellow or green discharge, and it's going to be frothy. And then you'll also see that strawberry cervix, so that punctate inflamed cervix. And then for your bacterial vaginosis, it's going to be a thin white-gray discharge. And then for our chlamydia, okay, we're going to see that mucopurulent discharge, right? In comparison to our gonorrhea, it's just a purulent discharge. And usually for treatment for this, remember, for chlamydia, it's going to be your azithromycin, or you can give doxycycline for 7 days. Okay, so now we're going to go into neoplasms, okay? So we're going to go into breast cancer. It's the second most common cancer-related death in women behind lung cancer. It's usually due to uncontrolled growth of epithelial cells in the breast, and it's usually based on hormone receptors. So you usually call them whether they're, and that's how we would call it during my surgery rotation. My doctor specialized in mastectomies, so breast removal in patients that suffered from breast cancer. And so you usually describe these as based on the hormone receptors, so estrogen receptors. If it's ER positive or HER2 negative or HER2 positive or ER negative, HER2 negative, that's how you describe them. And you have different types. So you have your ductal carcinoma, which is tumor cells from the wall of the duct into the lumen. And then you have your Paget's disease, which is basically an extension of ductal carcinoma in situ. You'll see eczematous patches on the nipple. They might show you a photo of that. So make sure you know how it looks. And then on histology, you'll see Paget's cells. You can also have lobular carcinoma in situ, which is basically where tumor cells grow within the lobules. That's why it's called lobular. But it does not involve surrounding tissues. That's why it's called in situ, because it's just located to the lobules, and it's usually often bilateral. And then we have the worst one, which is your infiltrative or invasive ductal carcinoma. It's the most invasive one. So some of the risk factors for these patients for breast cancer, if they're BRCA1 and 2 positive, if they had a family history, specifically if they had a first family member that had cancer, like say it's a woman whose mother died from cancer, that then they have a higher risk of having cancer, breast cancer. If they have breast disease, if they're older than 70, if the patient never breastfed, so make sure that you know these risk factors, because they might ask you a question of which factors are protected against breast cancer and then which factors are not protective, or which of these risk factors makes a patient more prone to getting cancer, breast cancer. So a patient that has never breastfed, if the patient is on an oral contraceptive use, oral contraceptives have a possible side effect of increasing your risk for breast cancer. Hormone replacement therapy, if they had radiation, if they have chronic diseases like hypertension, diabetes, mellitus, stress, smoking, if they have increased estrogen exposure, like if they're obese, if they've never had children, like nulliparity, that scares me because I don't have any children, if they had early menarche and late menopause, right? So the more prone you are to hormones. So a woman that goes earlier into menstruation, or they have an early menstruation like at age 9 or 10, and they have a later menopause like at age 55, then you have more years of that hormones, of your body releasing hormones. So that's why it makes you more prone to getting breast cancer and your uterine cancers. So that's why I make sure that you know that, because I had a question on that. Early menarche and late menarche are associated with increased breast cancer and also increased uterine cancer probability. And then also your late first pregnancy. So if a woman had a child after the age of 30 or 35, then they're at an increased risk of developing breast cancer, right? Because you are more prone, you're having more hormones during that time. So what are some of the protective factors? So protective factors are breastfeeding parity, so if the woman has had a lot of children, if they've exercised, if their postmenopausal BMI is less than 23, if they had an oophorectomy at age less than 35, and then aspirin. So how is it going to present? So breast cancer, you'll have firm, immobile, painless breast lump or thickening, okay? So it's going to be a painless lump or thickening. They'll also have the peau d'orange, okay? Basically, what does that mean? That's basically dimpling, right? If you look at an orange, I have a mandarin here, and if you can see it, you see how it has like little dots around it. This is what a peau d'orange is, okay? Basically on the breast, so have like little dots. It'll have dimpling. That's what it is. The patient can also have nipple discharge. Usually it'll be unilateral, okay? Bleeding, change in color and appearance of the areola. The nipple can also be inverted. They can also have axillary lymphadenopathy, and then usually the most common location is going to be in the upper outer quadrant, right? So diagnosis, you're going to diagnose this with the breast exam. You can also do a mammogram, and then an ultrasound or MRI also, but you're going to confirm with the fine needle aspiration biopsy. You can also do some labs, like you can do a serum calcium, alkaline phosphatase, estrogen and progesterone receptors. And then treatment is that you always want to make sure that you save the breast. So as much breast tissue as you can, you want to save. So you start with a partial mastectomy. If you can't do a partial mastectomy, then you go into a radical mastectomy. Also, some of these patients might need radiation or chemotherapy, depending on what type they have. Also some hormonal therapy if the cancer is responsive to hormonal therapy, like your positive ones that we were discussing, like your EOR positive ones, then you can do hormonal therapy for these, like tamoxifen. Okay. So basically, if a patient has a breast mass, what you're going to do is you're going to do a history and you're going to perform a clinical breast exam, right? If you do the examination and they have no mass, then you can do a clinical examination in 2 to 3 months. If you do the examination and you feel mass, and the patient's usually younger than 30 years, then you can order an ultrasound, okay? Right, because women that are younger than 30 years old, they don't have as much breast tissue, so it's easier to see the breasts and the lumps with an ultrasound. Versus a woman that is older than 30 years old, then with them you do want to do a mammography, or with or without an ultrasound if needed. But with them you want to do a mammogram because they have more breast tissue. And then if you do the examination and then you see a very suspicious mass, like it's fixed there, the borders are not normal, it's painless, then you can order diagnostic mammography and ultrasound, regardless of the age. So types of breast cancer, like we said, you have your non-invasive, which is your lobular and ductal. You have your invasive, which is your lobular and ductal. Others, Paget's disease, and then you have your inflammatory ones, and then also the ones found in men. Okay, so let's go into cervical dysplasia. So cervical dysplasia is usually a precursor to cervical cancer, so you want to be very careful with these patients that have this. It's also known as cervical intraepithelial neoplasia, CIN. It's most commonly found in the squamo-columnar junction of the cervix. Causes, etiology is usually human papillomavirus 16 and 18. Remember, we discussed that earlier, which strains are bad, 16 and 18. And then CIN is more commonly found in women that are in their 20s. Risk factors are smoking, if they had the DES exposure, okay, whether their mom had the DES exposure, if they have a history of sexually transmitted infections, early childbearing, if they had early first intercourse. So the younger these patients are at having sexual intercourse, the more prone they are of getting cervical dysplasia or getting an HPV infection, right? Because these patients are naive. Signs and symptoms, asymptomatic. They can have some abnormal vaginal bleeding or malodorous discharge. Postcoital bleeding, that's actually one of the big ones. So if you have a patient that is young and they're complaining of bleeding after intercourse, you want to rule out cervical dysplasia or cervical cancer. They can also have a pelvic pain or pressure. So screening. So your pap smear starts at age 21. This is actually something new, okay? I know in the past it used to be age 18, but they found no need for that. So now it's pap smear starting at age 21. Make sure that you know that. And then after that, every 3 years. And then you start doing the pap smear and the HPV testing at age 30. So you confirm if you think that a patient might have cervical dysplasia with the colposcopy with a biopsy, and then also HPV testing. So CIN1 is going to be mild dysplasia, so basically 1/3 of the epithelium of the cervix. CIN2 is going to be moderate dysplasia, so 2/3 of the epithelium. And then you have CIN3, which is severe dysplasia, right? The entire epithelium. So that's how you can memorize it. It's going to be 1 out of 3. CIN1 is 1/3, CIN2 is 2/3, right? And then CIN3 is just severe, it's the entire epithelium. So you're going to manage this according to the ASCCP guidelines. Make sure that you're familiar with these guidelines because it is just, I was listening to podcasts and a lot of doctors, like internal medicine doctors and family medicine doctors, it's just something that's really confusing. Even one of the OB-GYNs that I was listening to, she's like, sometimes I have to go back and refer to these guidelines because it's just so confusing. So just make sure you take a look at that. Okay. So for atypical squamous cells of indeterminate significance, also known as ASCAs, that's one of the big ones that you're going to be asked. Treatment, if it's less than 30, you're going to repeat in 1 year. If they're greater than 30 and they have an HPV test that is positive, then you're going to do a colposcopy. So basically, and if they're greater than 30 and they're HPV negative, then you're going to repeat the exam in 3 years. And if you can't exclude ASC-H, then you're going to do colposcopy. So for a patient that has low-grade squamous intraepithelial lesion, so LGSIL, which is known also as mild dysplasia, treatment is going to do a colposcopy if they are HPV positive. If they have high-grade squamous intraepithelial lesions, so HGSIL, and it's moderate or severe dysplasia, then you're going to do a colposcopy or a loop excision. So cervical cancer basically is dysplasia. It's an abnormal growth of cell on the surface of the cervix. It's cancerous. What are the causes once again? HPV type 16 and 18, if the patient was smoking, they have an STI history, DES exposure. The most common type is going to be squamous cell carcinoma and adenocarcinoma. Signs and symptoms, once again, postcoital bleeding, pelvic or prime pressure, pelvic pain or pressure. Sometimes it can be asymptomatic. Screening for this, it's going to be pap smear. You're going to start at age 21 once again, and then after that you're going to do it at every 3 years, and then you're going to start pap smears and HPV at age 30 to confirm, right? Any type of cancer, what are you going to do? You're going to do a biopsy. So you're going to do a colposcopy with a biopsy. And then for mild dysplasia, you're going to repeat a pap smear every 6 months to ensure that the dysplasia is not getting worse. For moderate or severe, you're going to destroy any abnormal tissue through conization, hysterectomy, fertility treatment, chemoradiation, and then usually how are you going to prevent this? You're going to prevent this with HPV vaccination, so Gardasil. So now we're going to go into vaginal cancer. It's a very rare cancer. It's actually about 1% of the GYN gynecological malignancies, and it tends to occur in the upper 1/3 of the vagina. The most common type of vaginal cancer, make sure that you know this, is going to be squamous cell carcinoma, and it's more commonly found in older people, so ages 60 to 65. If the patient's younger, like if they're 19 or 20, then the most common cause is going to be adenocarcinoma. What are some of the risk factors? HPV 16, if they had cervical or vulval cancer, if they are immunosuppressed, if they smoke. Smoking is a big one, okay? So make sure that you know that, smoking. Also, if the patient's postmenopausal, DES exposure, so make sure that you know that. DES exposure, it's a type of drug that used to be prescribed in the past, and they stopped prescribing it because it was causing cancer. Symptoms, they can be asymptomatic. The patient will be complaining if they do have symptoms of abnormal vaginal bleeding, watery vaginal discharge, and painful sexual intercourse. How are you going to diagnose this? You're going to do a biopsy. Like I said, it's most commonly found in the upper 1/3 of the vagina. And treatment tends to depend on the location, on the size and staging, but usually it's surgery, radiation, and chemotherapy. It's a very rare cancer. And usually the patient will present when they're older. Next one, we're going to go with vulvar cancer. It's a cancer of the outer female genitalia. Some of the precursors are usually lichen planus, lichen sclerosis, and a wart-like lesion. Make sure that you know the difference between lichen planus and lichen sclerosis and vulvar cancer, because they could present very similar. I had some questions where I thought it was vulvar cancer and it was actually lichen planus. Some of the causes or etiology: obesity, young, usually if the patient is HPV positive, if they're smoking. If you notice, most of these cancers that are related in women is due to HPV. Whether they are immunosuppressed, if they have diabetes, hypertension, coronary artery disease, and the most common type of vulvar cancer is going to be squamous cell. But you also have melanoma and Paget's. Signs and symptoms for vulvar cancer, okay, the patient's going to be complaining of chronic itching. This is pathognomonic for vulvar cancer. Patient's going to be coming in, they're complaining that they're very itchy in their vaginal area. They'll have some burning, vulvar lump, postmenopausal bleeding. They might have some bloody discharge. It might be discolored. They might have some growing lymphadenopathy. You're going to diagnose this with acetic acid vinegar. You're going to also use staining with Toluidine blue, and you're going to confirm once again with a biopsy. Treatment first line is you're going to excise it, right? And then surgical resection, so radical vulvectomy, and then radiation or chemotherapy depending on how advanced it is. So now we're going to go into endometrial cancer. This one is usually due to estrogen, so it's estrogen dependent, and this is actually one of the most common causes. We have different types of endometrial cancer. We have estrogen dependent, which is the most common one, and it's found in young perimenopausal women. And then we have estrogen independent, which is found in older postmenopausal women. The median age tends to be around 58. The patient's going to be Caucasian, female, and oral contraceptives are a protective effect, right? So why? Because it thins lining and it does not cause overgrowth of the endometrial lining. Usually if there's an overgrowth of the endometrial lining, it becomes abnormal, and this can cause cancer. So if the patient is taking oral contraceptives, it's going to thin their endometrial lining and protects them. And the most common type of endometrial cancer is going to be adenocarcinoma, so make sure you know this. Make sure they're familiar with the types of cancers. So most common type is going to be adenocarcinoma. Type 1 is most common. It's like we stated, it's found in younger women. They might have some unopposed estrogen exposure, amenorrhea, but they have no symptoms of menopause. And then you have type 2, which is independent of estrogen, like we discussed, found in older women. It's due to endometrial atrophy. They have a high risk of relapse, and they have very poor prognosis with type 2. So risk factors: if they have unopposed estrogen stimulation, this is why you have to be really careful in women that are postmenopausal with prescribing them estrogen only. You want to make sure you're very careful because this can cause endometrial cancer. Also, obesity, nulliparity, early menarche, late menopause, polycystic ovarian syndrome is a huge one. I had a question on this and I got it wrong. Chronic anovulation, family history of breast cancer, colon cancer or endometrial cancer, history of endometrial hyperplasia, diabetes mellitus, hypertension, infertility. And once again, oral contraceptives decrease their risk. Diagnosis: so the gold standard is going to be a Pap with an endometrial biopsy. If you notice, most of the cancers require a biopsy for diagnosis. You can also do a hysteroscopy, so you go in there and you see you examine it, the uterus. You can do a transvaginal ultrasound, and then the tumor level is going to be the CA125 marker. Treatment is going to be a total hysterectomy with a salpingo-oophorectomy, so you go in there and you take everything out. You can do radiation also, depending on how advanced the disease is. If it comes back, a recurrence, then you can do high-dose progesterone and anti-estrogens to avoid recurrence. And the most common site of metastasis is going to be the lungs. So now we're going to go into endometrial hyperplasia. So endometrial hyperplasia, it's estrogen dependent. It's due to overgrowth of endometrial lining. So basically estrogen builds and progesterone breaks down, like we stated earlier. And causes is usually due to increased estrogen exposure. Once again, you want to be careful with women that are postmenopausal because their hormones are not working as a woman that is premenopausal. You want to avoid any type of estrogen because what does estrogen do? Builds. It can cause hyperplasia or just abnormality in the endometrial lining, and that can predispose a woman to having endometrial cancer. obesity, nulliparity, PCOS, late menopause, and anovulation. So you have simple, which is increased number of glands with no crowding. You have complex, which is increased number of branching glands with crowding. You have atypical, which is increased number of typical gland with crowding. And atypical hyperplasia is the most common one that has the highest risk of progression to endometrial cancer, right? Because you have increased number of atypical gland with crowding. Signs and symptoms, it's going to be abnormal uterine bleeding, specifically if a woman comes and complains and they're postmenopausal. Women aren't supposed to be bleeding if they're postmenopausal and they're having bleeding, then you want to make sure that you have endometrial cancer or hyperplasia on your differential diagnosis. We saw a lot of this during my OB-GYN rotation. It's really sad. Diagnosis, you're going to do a gold standard, which is with a tissue biopsy, because you want to go in there and see what type of cancer it is and see if it is cancer. Treatment, simple. If it's simple or complex, like we talked about earlier, then you can just do progesterone therapy, which, what does progesterone do, right? It basically breaks down that tissue and it thins the lining. So for example, you can do something like Provera for 10 days. If it's atypical, which is the one that has the highest risk of progression to endometrial cancer, then you can do something like a hysterectomy because this has a high chance of invasion. So now we're going to go into ovarian cancer. So ovarian cancer is the most common cause of OB-GYN cancer deaths. Basically, it's found in women that are aged from 40 to 60. Long-term oral contraceptive use is protective for ovarian cancer. So as we saw, oral contraceptive use is protective for endometrial ovarian cancer, but sometimes it can increase your risk of breast cancer. That's the only one. But with ovarian cancer, it is a protective effect. And there's different types. There's epithelial, which is commonly found in women over the age of 50. There's stromal, and then there's germ cell type, which is found in young women. So usually the woman will be an older Caucasian woman. They'll be nulliparous, so they didn't have any children. They have problems with infertility. They might have a family history of ovarian cancer, history of endometrial cancer. They might have the BRCA1 or BRCA2 mutation. And usually the first pregnancy, if they do have children, it'll be after the age of 35. Signs and symptoms, sometimes they might not have any specific symptoms, but in the question stem, they will give you ascites, abdominal distension, weight gain, or weight loss. So usually if you read a patient, it's a woman, they're having ascites, abdominal distension, they might have some vague GI symptoms like constipation, weight loss, and then there's an adnexa, then make sure you think about ovarian cancer. So they'll have an adnexa that's tender with a fixed mass. Diagnosis is with a pelvic exam, a pelvic ultrasound, and then usually their CA-125 tumor marker is elevated. Treatment is going to be surgical removal. You also want to do chemo and radiation. This one has a very poor prognosis because usually when it's diagnosed, it's very advanced. Okay, so now we're going to go into disorders of the breast. So we have fibrocystic disease, which is basically a non-proliferative benign lesion of the breast. It's the most common cause of cyclical breast pain, and it affects more than 50% of women. It's usually due to hormonal imbalances. Basically, there's proliferation of normal breast tissue with estrogen stimulating the ductal elements and then progesterone stimulating the stroma. Lesions are associated with benign changes in breast epithelium. So what is the patient going to be complaining of? Basically, they're going to be complaining of breast tenderness and pain, swelling. They might have some nipple discharge that's non-bloody. They might also have some discomfort that is usually increased during the premenstrual phase of their menstrual cycle. They might have some fluctuations in the size, the appearance and disappearance of a mass. And if you notice, this is usually multiple. So they'll have also multiple mobile masses. It'll be bilateral, okay? Versus a fibroadenoma, it's usually a single one. With fibrocystic, it's going to be multiple bilateral mobile masses. And they're not going to be fixed, right? Because if it's fixed, what does it usually do? It might be cancer. You're going to diagnose this with what? So if a woman is younger than 30, you do an ultrasound. Anything that's breast related, okay? Less than 30, ultrasound. Greater than 30, then you can do a mammogram. And then you're going to confirm with the fine needle aspiration biopsy. Treatment, it's going to be usually conservative first. So you want to make sure that they're avoiding caffeine, they have a fat diet, they use support garments. That was one of the big ones that I had for questions that I asked you. What was the treatment for fibrocystic disease? Support garments. compressions, and then symptoms tend to go away after menopause, right? Because you're not having those hormones affecting the cysts. And then if the patient has tried all of this or they want pharmacotherapy, then you can do oral contraceptives, which is first line. So oral contraceptives, first line. And then other things you can do is like danazol, bromocriptine, GnRH agonist. If they have mild mastalgia, like mild breast pain, then you can consider something like NSAIDs. And then if they have severe mastalgia where NSAIDs aren't working, like ibuprofen, then you can consider something like tamoxifen, right? So now we're going to go into breast fibroadenoma. This is another benign breast tumor. It grows very slowly. It's also related to hormones. And the size tends to be about 1 to 5 centimeters. It's commonly found in younger women, and it can increase in size during pregnancy or with estrogen. Risk factors is usually pregnancy for this. And then on exam, you'll see a single, like I said, single round, smooth, firm, rubbery. That's a huge, it's pathognomonic for breast fibroadenoma. It's going to be a single, rubbery, mobile, well-circumscribed, non-tender mass. So like I stated, anything that's not well-circumscribed and it has abnormal shape, then you want to, and it's fixed, you want to consider cancer. But with this one, it's well circumscribed, non-tender mass, and it's usually unilateral, but it can sometimes be bilateral. Diagnosis, as we discussed with fibrocystic disease, if they're younger than 30, it's going to be an ultrasound. If they're older than 30, it's going to be a mammogram. And then prenatal aspiration biopsy for cytology. My doctor did a lot of this. We had a lot of fibroadenomas that came in, and patients wanted to ensure that it wasn't breast cancer, so we would go and take them into the surgery and then do a quick fine needle aspiration on them. Definitive, though, is going to be a core needle biopsy with excision if the patient's usually older than 30 or if they have a strong family history of breast cancer, okay? So definitive, and if you read in the question stem that the patient has a family history of breast cancer or they're BRCA1 or BRCA2 positive, for example, then you can do a core needle biopsy or excision if they're older than 30. Treatment is usually observation. You want to make sure that it's not growing. And you do this with repeat ultrasounds every 3 to 6 months. And that's what we did in clinic with my surgeon. And then you can remove him if the mass changes or it's enlarging, just to make sure that it's not breast cancer. So mastitis. Mastitis is inflammation of the breast, usually due to breastfeeding, right? You have that milk that just stays there. Injury to the nipple, whether it's the baby that usually injures the nipple, poor attachment of the infant, and the most common bacteria in mastitis is going to be Staph aureus. So make sure that you know that, okay? Staph aureus, that makes sense, right? Because Staph aureus is found all over the skin. So that's the most common cause of mastitis. It's going to be Staph aureus. Signs and symptoms, it's going to be unilateral, swollen. The patient will usually have like a wedge area of the breast. They'll be complaining of pain, redness. You'll see induration, okay? Small fissures, hardening. And then if it's systemic, they might have some symptoms like a fever, malaise, chills. On diagnosis, it's usually clinical. If you do decide to do labs, you can do a CBC and you'll see leukocytosis, right? Increased leukocytes because it's a bacterial infection. Treatment, you're going to tell the patient to continue breastfeeding. So just because they have mastitis and infection doesn't mean they have to stop breastfeeding. And I had several questions on this, so it'll usually ask you what is the next step, best step for patient education for this patient. If they present and they're complaining of this, then you tell them that they can still continue breastfeeding, okay? It's actually good. You're also going to tell them the rest, fluids, give them some oral antibiotics like dicloxacillin or cephalosporin. But dicloxacillin is the treatment for mastitis. So now we're going to go into breast abscess. It's basically a bacterial infection that can cause pus, and it's usually localized in the area in the nipple, near the nipple, and the areola. Some of the causes is due to breastfeeding mastitis, so milk stasis like we stated, and then the most common bacteria, once again, is going to be Staph aureus. Signs and symptoms, the patient will have a warm, tender erythema, induration. They might have a fluctuant mass. So fluctuant mass is going to be pertinent to breast abscess. So make sure that you know that. Fluctuant mass, breast abscess. They might have some nipple inversion. They'll have fever, chills, malaise, also lymphadenopathy. How do you diagnose it? You're going to aspirate. So aspiration and discharge, and then send for culture and sensitivity to see what type of bacteria it's causing. But most common one is going to be Staph aureus. Treatment, you're going to treat with antibiotics. You can do also an IND, so incision and drainage. And once again, with these patients, you tell them the same thing. If they ask you, do I have to stop breastfeeding? No, you do not have to stop breastfeeding. So just to review real quick with the breast disorders, if it's a fibroadenoma, right, it's going to be a painless, single, mobile, slowly growing breast mass. It's usually characterized like a breast mouse, right, because they tend to slip under the hand when you're doing the breast exam. And then fibrocystic disease, it's going to be multiple masses, and it'll be usually bilateral. And then mastitis, it's basically inflammation, also known as cellulitis of the breast tissue. And the most common bacteria for this is Staph aureus. And the most common bacteria for breast abscess, you'll see fluctuant mass, is going to be Staph aureus. So now we're going to go with structural abnormalities. Okay? So ovarian cysts, basically it's a fluid-filled sac within the ovary that is due to disruption of follicles or corpus luteum. The most common type is follicular cyst. Usually the majority of them are benign, and it's found in a woman of reproductive age, so a younger woman. It's due to usually hormonal imbalances. Signs and symptoms, they're going to be asymptomatic. If they do have symptoms, they'll complain of bloating, lower abdominal pain, low back pain, painful sexual intercourse, and then only will the patient have severe pain with these cysts is if they rupture or if they torse, right? So just like in males, they have testicular torsion, where the testicles can basically spin on themselves. Same thing with the ovaries, is that they can twist, and we'll actually discuss that in a few minutes. Diagnosis is going to be with a pelvic ultrasound, and then you'll see a smooth hypoechoic with fluid levels, and then if the cyst has ruptured, then they'll have some free fluid. It's most commonly found in the pouch of Douglas. Treatment, like I said, these are benign, they're asymptomatic. Usually a woman will have them and they don't know they have them. So usually treatment is none if they're asymptomatic, but you want to make sure that you are observing them to make sure that they're not getting larger. Sometimes they go away by themselves. But if the patient does want to get them removed, then they can have something like a laparoscopy, where they go in there and they remove in like a cystectomy or an oophorectomy. If it ruptures and they're stable, you can just give them pain management and observe them. If they're unstable and they're like bleeding a lot, they're in a lot of pain, then you would consider like a laparoscopy to control the hemorrhaging. So now we're going to go into ovarian torsion. It's basically when an ovary becomes twisted around the tissue that it supports and it cuts off blood supply. So the ovary can become ischemic, and this is an emergency. Usually you'll see this in the ER. I saw a lot of these in the ER. Very painful. Some of the etiology, if a patient has an ovarian cyst, usually if it's a really large ovarian cyst. Endometriosis, if they have a history of a strenuous physical activity, if they're pregnant, if they have tumors. Signs and symptoms, this is going to be an acute and sudden onset of severe lower quadrant abdominal pain and nausea and vomiting. And if you notice with this one, they're not bleeding, so this wouldn't be anything related with an ectopic pregnancy. They just have acute sudden onset, severe lower quadrant abdominal pain, and nausea and vomiting. And sometimes they'll have a history of ovarian cysts. Diagnosis, you want to rule out anything that's pregnancy related, like I said, like an ectopic pregnancy or an abortion. So you want to do a beta HCG, and you want to confirm with an ultrasound and Doppler. And you'll see no blood flow, and you'll see that's enlarged ovaries. Treatment is going to be surgical laparoscopy. You want to go in there and detorse the ovaries, or laparotomy. If it's necrotic, like it's already died, then you're going to go in there and do an oophorectomy. You're going to remove the ovary that is necrotic. So now we're going to go into polycystic ovarian disease. So basically this is a hormonal disorder. Basically ovaries develop small collections of fluid follicles and they fail to release eggs. It's very common in women of reproductive age. They'll have hyperandrogenism. Risk factors is that they have a family history of PCOS. They have a history of being obese. And complications of PCOS, if it goes untreated, is infertility and diabetes mellitus. Signs and symptoms, patients will be complaining of abnormal menses, weight gain, hirsutism, which is basically excessive hair growth, whether it's in the face or other areas, most commonly in the face, acne, right? And they'll have this hirsutism, right? Why? Because they're having the hyperandrogenism. androgenism. So they have increased androgens, which can cause all these masculine features. They can have acne. Usually these patients, like I said, they're going to be obese. They're going to have acanthosis nigricans because some of these patients are usually diabetic when you diagnose them, or have a history of diabetes. So acanthosis nigricans, right, is like the thick velvety skin in the back of the neck that you see that a lot of diabetics have. Diagnosis is going to be with a pelvic ultrasound. You'll see like these enlarged ovaries. You can also do androgen levels, which are going to be increased. Total or free testosterone, which will also be increased sometimes. And then a luteinizing hormone and FSH level also, follicular stimulating hormone. Treatment, you're going to tell the patient that to lose weight. Okay. Put them on oral contraceptives. This is going to help normalize their abnormalities with their hormones. It'll normalize their menses. It'll get rid of the acne. And then metformin, since most of these patients are diabetic. And Clomid. Basically, this helps with infertility, especially for those patients that are trying to conceive and they can't because they have PCOS. And it also induces ovulation. So make sure that you're reading the question correctly. If you have a patient with PCOS and they want to have children, what's the best line treatment? You can give them something like Clomid, right? You're not going to give them an oral contraceptive. But if it's tell you what is a first line measure for treatment, then you can do conservative like weight loss. If not, then it's going to be oral contraceptives. Endometriosis. So endometriosis is basically endometrial cells that are present outside of the uterus. It's the most common cause of pelvic pain in adolescents, and it's a very chronic and painful condition. Etiology, early menarche, nulliparity, if they have a family history of first-degree relatives, if their age is between 25 to 29. And what are the complications of endometriosis is infertility. So a lot of women that suffer from endometriosis suffer from infertility also. Signs and symptoms for this one, painful menstruation. So whenever you see a patient that has painful menstruation, they have painful sexual intercourse, especially with deep penetration, and they're infertile, then you want to think about endometriosis also. They'll also have some premenstrual pain during menses. They can also have dyschezia, which is basically excessive straining with stools. Because endometriosis, like we said, it's cells that are present outside of the uterus, so they can be anywhere, and sometimes they can be compressing. They can be in the pouch of Douglas, so they can be compressing your rectal area, and the patient has trouble going to the restroom. Diagnosis is going to be, initially, you're going to start with a pelvic ultrasound, right? You're going to go in there, and that's when you'll see the abnormal growths. But definitive treatment, it's going to be a laparoscopy with tissue specimen. And then usually you'll see a powder burn appearance. This is pathognomonic for endometriosis. So once again, if it asks you what is a definitive diagnostic treatment for endometriosis, it's going to be a laparoscopy. If it asks you what is the next best step or the initial test for diagnosis, then you're going to do a pelvic ultrasound. And then, of course, you want to do a beta-HCG to rule out any type of pregnancy. Treatment, if the patient's asymptomatic, you're going to do observation. If they're having severe symptoms, so the severe painful menstruation, which is very common, then you can do surgery. You'll go in there and you'll get rid of lesions, so ablation of lesions. You can do a hysterectomy with oophorectomy if the patient does not want to have children in the future. And also another thing you can do is oral contraceptives. You can give them progesterone also, GnRH agonist, which is one that I kept seeing, like Leuprolide, Danazol, and then levonorgestrel releasing IUDs also. But this is more second-line treatment. Okay? So observation, if they're asymptomatic, if it's severe and they've tried everything and it's not going away, then you consider surgery. But usually if they want some type of pharmacotherapy, you can give them oral contraceptives. Like I said, I saw a lot of GnRH agonists like Leuprolide, and then progesterone. So now we're going to go into fibroids, so also known as leiomyoma. So make sure that you know that leiomyomas are fibroids, because it's usually on the question stems, it will not say fibroids, it will say leiomyoma as an answer choice. So this is a benign fibroid mass. It's the most commonly located intramural. If it's located subserosal, it's least likely to affect the menses. Most commonly found in African American women. So you'll have a question that will ask you what type of individual is most prone or most commonly found for fibroids. It's going to be an African American woman. Usually these women will have an increased BMI, they'll have a family history, they'll be nulliparity, so they won't have any children. Signs and symptoms, most common is menorrhagia, right? So they'll have a lot of bleeding during their menstruation, they'll have dysmenorrhea, painful menstruation, spotting, abdominal pain, urinary frequency and urgency. They'll have back pain, dyspareunia, abdominal heaviness and fullness, and then you'll usually palpate an irregular mass on the uterus and an enlarged uterus also. How are you going to diagnose this? You're going to confirm it with a pelvic ultrasound, transvaginal. You'll see like these hyperechoic heterogeneous dark solid masses, and then also, as always, you're going to do an ECG to make sure you rule out any pregnancies. Treatment's going to be observation if they're asymptomatic, especially if they want to have children in the future or if they're near menopause. You can also give them some NSAIDs for their dysmenorrhea and oral contraceptives for the abdominal bleeding. And you can also give them progestins for the endometrial atrophy to decrease bleeding, something like you can also give Depo-Provera, you can give them an IUD, GnRH agonists like Leuprolide. And then surgery, you can do surgery if it's very severe and you've tried everything, or the patient just desires surgery, then you can do something like a myomectomy, which just goes in there and just gets rid of the tissue rather than getting rid of the entire uterus and the ovaries and everything. And this is usually done in women that want to have children in the future, so they want fertility is desired. You can also do endometrial ablations, but usually this is done in women that do not want to have children in the future. You can do fibroid embolization, so basically you go in there and you cauterize any blood going to the fibroids, or a hysterectomy, which is usually you go in there and get rid of everything. So now we're going to go into the contraceptives. Make sure that you know the types, because you're going to have multiple questions on these, whether it's on the EOR or on your practice exams. Make sure that you know the types of contraceptives and who you can give them to. So we have your oral contraceptives pills, which are regular. Basically, you take these every day, right? And they contain your ethinyl, estradiol, and progestin. They have a very low failure rate, which is about 1 to 2%. And they're very good at preventing pregnancy if the patient takes them every day. So going into the oral contraceptives a little bit more into detail, basically, when are these contraindicated in? So oral contraceptives, of course, are contraindicated in patients that are pregnant, if they have uncontrolled hypertension, so this is high yield. If the patient is a smoker and they're older than 35, you do not want to give them an oral contraceptive. If the patient has diabetes mellitus, if they have a history of venous thrombus embolism, because what do oral contraceptives do? They make you more prone to getting, they make you more hypercoagulable. Also, if the patient has a known or suspected breast cancer, and if they have migraines with aura. So make sure you know these contraindications for oral contraceptives, okay? So if a patient is a smoker older than 35 years old, if they have a migraine with aura, if they have a history of coagulopathies, okay? Hypercoagulopathies. Some of the adverse effects of the oral contraceptives is going to be breakthrough bleeding, amenorrhea, breast tenderness, weight gain, although this is not really, a lot of people debate still on the weight gain. And it increases the risk of cardiovascular disease like myocardial infarction, strokes. So now we're going to go into Yaz, also known as drospirenone. Basically, it's an anti-androgenic and it's an anti-mineralocorticoid, has anti-mineralocorticoid activity. This is usually used for like premenstrual dysphoric disorder, premenstrual syndrome, moderate acne vulgaris. And then some of the contraindications is if a patient has renal or adrenal insufficiency, if they have hepatic dysfunction, and adverse effects are hyperkalemia. So now we're going to go into Ortho-Ever, which is a transdermal patch I discussed earlier. Basically has progestin and norelgestromin. It's a weekly contraceptive patch that is applied to the buttocks, the upper outer arm, the lower abdominal or upper torso. And basically the patient needs a new patch every week for 3 weeks, and then 1 week patch free. Okay, so if a patient doesn't want to take oral contraceptives, then they consider taking these patches, but it's 1 week, once a week, every week, and then the 3rd week you take it off. Some of the contraindications, if a patient has an increased risk of venous thromboembolism, side effects is that they can have skin reactions, right? They can have painful menstruation, breakthrough bleeding. Breakthrough bleeding is one of the big ones for transdermal patches. So if a patient wants something and they don't want anything that has to do with breakthrough bleeding, then you definitely do not want to give them the patch. So we're going to go into the NuvaRing next, which is basically has progestin and etonogestrel. This is a monthly vaginal ring, and these rings should be refrigerated. They have shelf life of 4 months. So for up to 4 months, these patients can use these, and then they have to get a new one. It's inserted within 5 days after the onset of menses, and it's left in for 3 weeks. And then you remove it on the week that the patient's going to have menstruation. And then you can put it back in the refrigerator if needed. It can be removed for coitus, and then it can be replaced in 3 hours. So some of the adverse effects with this one is that they'll also have breakthrough bleeding. And then some of the women and men report feeling it when they're having intercourse with the NuvaRing. Okay, so now we're going to go into the progestin-only products. So we have the progestin-only pill, which is a mini pill. I was listening to a podcast and they were asking, is it really a mini pill? And it really isn't. So basically what it does is that it inhibits ovulation. It's only progestin by suppressing luteinizing hormone, and it thickens the cervical mucus, okay, which makes the endometrium unfavorable for implantation, right? So it thickens the cervical mucus. It's harder for an egg to be implanted. So this is good for women that are increased risk for cardiovascular disease. So if they have a history of hypertension, then you can consider something like this. But something that is high yield that you have to know about progestin-only pill is that you can use this for lactating women. This is actually one of the ones that is suitable for lactating women. So make sure that you know that. If you have a woman that is lactating and they want to take some type of contraceptive, then you would consider a progestin-only pill. So some of the contraindications for progestin-only pills is that patients that have breast cancer, hepatic neoplasms, because some of the oral contraceptives are known to cause hepatic adenomas, although these are benign. And then some of the adverse effects is that they also have a higher incidence of bleeding. They might have amenorrhea, intramenstrual bleeding, prolonged periods of menorrhagia, and this one has a higher pregnancy rate. So now we're going to go into Depo-Provera. This one has a slower absorption. It basically inhibits ovulation. It causes changes in the endometrium and cervical mucus, once again, because it's a progestin pill, right? This one is given intramuscular. It's an injection that's given every 90 days. It's good for women whom an estrogen-containing contraceptive is contraindicated. So for example, if a patient has migraines, a history of migraines, sickle cell anemia, then fibroids, and you could consider something like a Depo-Provera shot. But with this one, like I said, it's an injection given every 90 days. So if a patient doesn't like injections, then you would not consider this, right? So basically, side effects for this one, patient's going to be complaining of irregular bleeding, amenorrhea, weight gain, and this should not be used longer than 2 years because it can cause decreased bone mineral density. Okay. Next one, we're going to go into the barrier methods. So we have the condoms, the diaphragms, the cervical caps. These are easy access, right? You can buy them over the counter. They're cheap, and they protect you against STDs. And they are reversible. So some of the disadvantages for this is it's highly dependent on adherence and proper use. So if the patient does not use it correctly, then it's not going to protect them against pregnancy. And some of the rare side effects is that they can cause toxic shock syndrome, especially with the diaphragms and contraceptive sponges. And then we have sterilization. This is usually reduces the risk of ovarian cancer, and it is permanent and irreversible. It's the most common use method. Some of the examples, right, are the hysterectomies, your tubal ligation, your vasectomy. And some patients usually tend to regret undergoing tubal ligation. And they can also have a higher incidence of getting an ectopic pregnancy with these. So now we're going to go into IUDs. These have a very high level of efficacy. And then you have different types. So you have your Mirena, which is good for women with menorrhagia. And also it's good for women with menstrual periods that have abnormal heavy or prolonged bleeding, which is menorrhagia, right? Skyla, which is also used, and this one's changed every 3 years. And then the Mirena's changed every 5 years, and the Paragard can last up to 10 years. So if you have a patient that they don't want to take any oral contraceptives and they want something that's going to last for a long time, then I would consider an IUD, right? So the Mirena is up to 3 years, 5 years, 5 years for Mirena, Skyla is 3 years, and then Paragard is 10 years. So the IUDs are not used for women that are high risk for bacterial sexually transmitted infections. So if they have if they had any STI in the last 3 to 6 months, then definitely you would not consider an IUD. Some of the risk factor or adverse effects for this is that the Paragard does increase menstrual blood flow, so they can be complaining of dysmenorrhea. For the Mirena, they have more frequent spotting up to 6 months after placement, or they might have amenorrhea. So if you have a patient that does not want spotting, then I would not consider an IUD. Also, some of the side effects is that they can cause uterine perforation. The patient can expose it, so it can expose during the first year, and it's more common during the first month. But it's not associated with increased pelvic infection. So you also have the Implanon. That's the one that goes in the arm, right? It's up to 3 years of contraception, but this one also causes irregular bleeding, and it does not normalize. So a patient that does not want anything that causes irregular bleeding, definitely do not think about Implanon. And then we have the long-acting reversible contraceptives. So we have the copper-containing ones, which is a Paragard T380. So for this one's good for 10 years. So if you have a patient that wants something for more than 5 years, then I would consider the Paragard. Okay. Some of the contraindications for Paragard: a patient that has Wilson's disease, if they're allergic to any type of the component that the copper-containing Paragard has, you definitely do not want to use this in these patients. And then you also have the progestin-releasing IUD, also known as the Mirena, the levonorgestrel releasing intrauterine system. This one's good for 5 years, like we discussed. And then we have the Implanon, which I discussed earlier. It's a single rod that goes here. It's contraception up to 3 years. And those are our contraceptions. Make sure that you are familiar with these, with the oral contraceptives. Like we stated, we don't want to give these to patients that have migraines, patients that are older than 35 and are smoking, because they have a high risk of venous DVTs, right, or causing pulmonary embolism. And then you have your IUDs that tend to last a lot longer, up to 5 years, up to 10 years, like your copper IUDs. So you also have the ones that go here, so they're not as invasive, so your Implanons, but these are only up to 3 years. And then you have the not so effective ones, like they can be effective, but it depends on the use, like your condoms, your caps, etc. And then also, before I forget, we're going to discuss the Plan B1 step. Basically, it's a pill. It's effective if you take it within 72 hours after intercourse, okay? And the hormone it contains is levonorgestrel. Okay, so now that we've done that, we're going to go into infertility. So infertility basically is a failure to achieve pregnancy after 12 months or 6 months if the patient is actively trying to get pregnant. Primary and secondary. So primary is the patient has never conceived. Secondary is that they have infertility after pregnancy. So they already conceived, but they haven't been able to have a child after that. That's secondary. Some of the causes is that they're obese, smoking, they might have endometriosis, polycystic ovarian syndrome, Turner syndrome, Asherman syndrome, which is a scarring, right? They might have fibroids or polyps. Diagnosis is that you're going to do a history and physical of both partners. So not only the female, but of the male also. And then for males, what you're going to do, first line, for males, it's going to be semen analysis. So if you have a question and it says that the woman's normal and the woman had a child from a previous marriage, but the male has never had a child and they're wanting to try and the woman cannot get pregnant, and it asks you what is the next first line diagnostic tool, then you would do a semen analysis, right? Because you want to make sure that the patient is having the normal amount of spermatocytes, etc. And then you can also do a testosterone level on the male. You can do a postcoital test, antibody studies, penetration assays. And then for the female, you can do an HPA axis. So you're going to look at the gonadotropin, the FSH, the LH, the estrogen, progesterone, prolactin, TSH levels. Make sure they're not hypo or hyperthyroid. Their androgen levels also. And then for the treatment for females, if it's something related to their cervix, then you can do them, give them low-dose estrogen. If it's due to tubal occlusion, then you're going to do corrective surgery, right? Or intrauterine insemination also. You can also do in vitro fertilization. For medication-wise, you can give them Clomid, which is an ovulation inducer, metformin, if it's something related to PCOS, right? You can also do gonadotropin and gonadotropin-releasing hormones like leuprolide. You can do progesterone, bromocriptine, if it's usually due to a pituitary adenoma. For males, you're going to do therapeutic insemination, so whether it's through intrauterine insemination or seminal deficiencies, or you can also do a donor sperm or intravenous fertilization. So now we're going to go into uterine prolapse. Basically, it's a weakening of the pelvic floor over time. There is no support. Okay. Some of the causes is going to be childbirth. Usually for uterine prolapse, you have a question with a woman that has like 5 children, so they've had multiple pregnancies. Aging as they're getting older, right? Their tissues are not as strong as they used to be, or their organs. If they have intra-abdominal pressure, like a history of obesity, of constipation, straining, lifting. If they have some type of neurological injury or estrogen deficiency. Signs and symptoms, this patient's going to be complaining of a heaviness or pressure, bulging without pain. Okay, so this isn't painful. They'll also have bladder or bowel dysfunction, weak sensation. They might have a history of UTIs. So diagnosis is going to be a pelvic exam. You're going to do a speculum and a bimanual. You can also do a rectovaginal. And then first degree, usually, so they're first degree and second degree and then third degree. With first degree, the cervix descends, but it doesn't protrude into the vulva. Second degree is that the cervix reaches the vulva on straining, and then third degree is that the cervix protrudes from the vulva on straining. So make sure you know between the first, second, and third degree. And then we have procedentia, which is basically the complete prolapse outside of the vulva. Treatment, first line, I have so many questions on this. It's going to be Kegel's exercise. So they're going to be doing the pelvic floor exercises. You can also do vaginal cones or pessaries. And then if they do require surgery, then you would do an anterior colpography. So basically make sure that for treatment for these patients, first line, it's going to be your Kegel's exercise. If they've tried this already, it's not working, then you can consider a pessary. My doctor placed a lot of these. Basically, it's like they're different sizes depending on the female, of course, and you go in there and you put it. But with these, they have to make sure that they're watching them and taking care of them. And if they've tried all of this and it's not working, or it's extremely severe, like you have something like procedentia, which is a complete prolapse, then you can consider surgery, like a hysterectomy also. So cystocele. Cystocele is bladder prolapse. It's an anterior vaginal wall defect. So versus uterine prolapse, it was a uterus. For this one, it's going to be the bladder. Causes, the patient's usually going to be postmenopausal if they have a history of a hysterectomy, numerous vaginal childbirths, elevated intra-abdominal pressure, so if they're obese. Signs and symptoms, they'll have heaviness or pressure/bulging, so they'll be complaining of a bulging. They might have some urinary retention, right? Stress incontinence, they'll have a history of UTIs, a weak urine stream, incomplete emptying. Diagnosis is going to be done with the pelvic exam. It's going to be an anterior vaginal wall defect. And then treatment, same as your uterine prolapse, it's going to be pelvic floor exercises, so your Kegels first, and then if the pelvic floor exercises are not working, then you want to consider something like your vaginal cones or your pessaries. And then surgery is usually like your last line or your definitive treatment. It's going to be an anterior colpography. So if the question asks what is a definitive treatment, then it's going to be surgery, right? Rectocele. Rectocele is basically a posterior vaginal wall defect associated with anterior prolapse of the rectum. So it's going to be a prolapse of the rectum. It's a defect in the rectovaginal septum. Some of the causes are vaginal childbirth, hysterectomies, so it's very similar to your cystocele, right? Increased intra-abdominal pressure, like the patient is obese. If they have some type of collagen abnormality, advancing age, and if they have an increased BMI. Signs and symptoms, patient is going to be complaining of pelvic pressure. Patient is going to be feeling as something's coming out of the vagina. They'll have constipation, fecal incontinence, sexual dysfunction, incomplete stool evacuation. They're having splinting to assist defecation. Diagnosis is going to be a vaginal and rectal exam, and then you'll feel a bulge in the posterior vaginal area with Valsalva. So as you notice, rectal seals is posterior, your cystocele and your uterine were anterior. Okay. And then treatment, it's usually you're going to minimize constipation and straining. You can do a pessary in place of pessary or surgical repair, which is definitive treatment, posterior colpography. So now we're going to go into urinary incontinence. So there's different types. There's urge, stress, and overflow. Make sure you know the difference between them and how to treat them. Urinary incontinence is basically involuntary leakage of urine, urge. So let's start with urge. It's basically a sudden sensation, right? As it sounds, like you're urging of needing to urinate because you have this overactive bladder. Okay, and it's usually an overactive bladder contraction by the detrusor muscle, commonly found in females, especially if they're older and if they are taking some type of diuretic. Symptoms, it's going to be the sudden urge or loss of large volume of urine. They have an increased urgency, nocturia, so they have the urge to go to the restroom, or they're going to the restroom more oftenly at night. Enuresis, so they're going to the restroom. Frequency. Diagnosis is that you want to do an ultrasound because you want to rule out an UTI, because most of these symptoms sound like UTI, right? But you're going to confirm with the urodynamic study. Treatment, you're going to tell the patient to avoid caffeine, bladder training, and if they do require pharmacotherapy, then you're going to do something like oxybutynin or mirabegron. So make sure that you know that. For urge treatment, it's going to be oxybutynin or mirabegron. Now we have stress. Stress is incontinence. It's a leakage of urine during coughing. So the patient's going to be saying that they coughed and they laughed and they felt a little urine coming out. Or if they exercised or if they sneezed. Signs and symptoms, it's going to be leakage during coughing. But these patients are not going to have any nocturia or urgency. Diagnosis is usually clinical. You're going to do a urine analysis, once again, to rule out UTI. You can also do the Q-tip test, which is not done in clinic at all. Treatment is, first line, it's going to be your Kegels exercise. You can do a Pessari also. You're going to tell the patient to lose weight, manage their fluids, and then surgery, definitive bladder lift, or urethral sling. Overflow. So overflow incontinence is due to a leakage of urine due to overdistension of the bladder. Okay? So basically the nerves are telling the detrusor not to empty. The nerves aren't working and there's a lot of urine in the bladder. And you have a neurogenic bladder. Usually commonly found in patients that are diabetic, if they just had surgery. Signs and symptoms, they'll have a high residual volume of urine, frequent or constant leakage or dribbling of urine without warning. Diagnosis is you're going to do a post-void residual with bladder ultrasound. You can also do a urodynamic testing, which is going to check for the detrusor muscle contractions. Treatment is you're going to do a clean intermittent catheterization, right? Because these patients have not gone to the restroom and they have a lot of urine. Surgical corrections if there's any type of obstruction, and you're going to discontinue whatever is also, if there's any type of medication that's causing this, then you're going to discontinue it. And then nerve stimulation also you can do for like last line treatment. Okay guys, so now we're going to go into sexual assault. So what is a sexual assault? It's a sexual act that's performed by one person on another without the person's consent. Whether it's genital, oral, anal penetration by the body or even an object. So on these patients, you want to make sure that you're going to get a good history. You want to ask them when was the last time they had consensual intercourse. You want to ask about their patterns, if they're taking any type of oral contraceptive use. Ask about their assault, whether there was penetration, whether there was any condom use, if there was any weapons, where it occurred, and when it happened. On diagnosis, you want to do a pelvic exam to make sure that there's not any tears or anything. You also want to do a beta HCG to rule out pregnancy, wet mount, to rule out any STDs, KOH prep, cervical culture. You can also do a X-ray of skeletal survey, so make sure that there's any fractures. Chest X-ray, a CBC if they lost a lot of blood. And then treatment, first line, it's going to be your ABCs, right? You want to make sure you do your airway, check their blood, check for circulation, their breathing. Prophylactic, you want to give them ceftriaxone, doxycycline, and metronidazole, right? To make sure that you treat against chlamydia and gonorrhea. And then you want to give them a hepatitis B vaccine and then emergency contraception. And then, of course, you want to cancel these patients because it was something that was very traumatic that happened to them. Now we're going to go into domestic violence. It's an abuse between spouses and partners, whether it's physical, sexual, or emotional. Usually the causes are alcohol abuse. It's most common in violent homes, and then it's most common in male to female violence, so the male to the female. So diagnosis is really no gold standard. Basically, you ask them, you do the CTS2, Okay, you can also do the safeguards. So you ask them if they're safe at home, right? Is their children safe? Are they afraid of their husband or their spouse? So SAFEGARDS, that's a mnemonic. So safe at home. Are their children safe? Are they afraid of their husband or their spouse? Do family and friends know about what's going on at home? Do they have an emergency plan? Like, are they planning on leaving or divorcing them? Is there a gun at home? Is there alcohol or drug abuse? What is their relationship with their spouse? Depression, so you want to ask if they're depressed, or you want to ask the singy caps, right? Which is their sleep. Are they sleeping? Do they lack interest in doing things? Do they have any feelings of guilt? Any loss of energy? Any loss of concentration? Any increase or decrease in appetite? Any psychomotor symptoms? Any trouble sleeping? Any thoughts of wanting to harm themselves, like suicidal ideations? And then if they have a strong support system. So safeguards, that's a mnemonic, SAFE space GARDS. And treatment is basically you want to counsel and inform them, give them information. So provide them information maybe with a woman's shelter, but you do not have to report it. It's not mandatory to report this. Versus child abuse, it is mandatory. With domestic violence, it is not. And usually you'll have a question with a family, a woman that comes in with her husband, and you notice all these injuries, and it'll tell you what's the next best thing to do. Obviously, you're not going to confront the husband. You can maybe ask the husband to step out, and then you can speak to her. You can give her some information on how she can seek help, but it's her decision if she wants to come back to him or not. So now we're going to go into prenatal care and normal pregnancy. Okay, so make sure you know the physiology of pregnancy. So what are normal things that happen in pregnancy? So they tend to have mild respiratory alkalosis, right? Because they're hyperventilating. They're more prone to being hypercoagulable. Their beta HCG, of course, is going to be increased. And then their HCG is usually detectable with blood and 1 week post-conception. With urine, you can detect it with 2 weeks post-conception, and then it'll double every 2 days in early pregnancy for the beta HCG. So make sure that you know that. It doubles every 2 days with your beta HCG. So with estrogen, it's initially produced by the ovaries, right? But then once the placenta and the baby starts growing, the placenta is going to take over. And then this one tends to rise over pregnancy. So estrogen rises over pregnancy, and then it drops right before labor. It's responsible for smooth muscle. It is responsible for preparing the body for delivery, and it increases oxytocin receptors in the uterus. So if you have a question that asks you which hormone is responsible for increasing oxytocin receptors in the uterus, it's going to be estrogen. Progesterone is needed to maintain pregnancy. Okay, placenta takes over the majority of pregnancy, and then once again, progesterone drops right before labor. So how I remember progesterone is pro-gestation, right? So you need it for pregnancy to maintain pregnancy. So pro-gestation, progesterone. Progesterone causes smooth muscle relaxant, and it maintains the uterine lining. So for respiratory, you'll see diaphragmatic breathing. This is usually because they have increased intra-abdominal pressure, right? They have that baby there. The patient's going to be hyperventilating, so respiratory alkalosis. They might be complaining of shortness of breath, and this is normal. Cardiovascular, they'll have increased cardiac output. They'll have decreased peripheral resistance and decreased blood pressure, so they'll be hypotensive. Hematology, they'll have increase in plasma volume, and this is due to the peripheral edema also that the patient can be complaining of. They'll have increased red blood cell volume. They can become anemic sometimes, and then they have an increase in clotting factors, so they're more prone to being hypercoagulable. So that's why you want to make sure that you tell these patients to walk if they can, because they're more prone to getting DVTs. Musculoskeletal, they'll be complaining of low back pain. They might have lordosis. They might have some carpal tunnel and sciatica pain. Muscle cramps also is very common. Dermatological, you'll see hyperpigmentation, distension or proliferation of blood vessels, and then your spider angiomas. Gynecological, they'll have breast enlargement, areolar pigmentation, uterine stretching, a lot of uterine stretching, cervical gland hypertrophy, so they'll have the mucus plug. And then urology, they'll have increase in GFR. This is because they have increased blood flow and increased urinary frequency, so they're going to the restroom more frequently. And then for GI, they'll have esophageal relaxation. So this is why a lot of these patients complain of acid reflux that are pregnant. They can also have increased intra-abdominal pressure. So these women are more prone to getting hemorrhoids, and then constipation for pregnant women. So prenatal diagnosis and care. So make sure that you're familiar with your GP, right? So gravida, G, is the number of pregnancies. Para is the number of births, okay? Term is 37 to 40 weeks. Preterm is any pregnancy that's less than 37 weeks, and abortion is less than 20 weeks. So signs and symptoms of a pregnancy: amenorrhea, nausea, vomiting, breast engorgement. Okay, they can have quickening, increased basal body temperature, chloasma, right, which is a hyperpigmentation right here, and it goes away after the woman has completed or has had the baby. They'll have the linea nigra, right, which is from the umbilical down. It's like a line, it's like a black line. They'll have striae, spider telangiectasias, Chadwick's sign, which is a blue discoloration of the cervix. They'll have a Heger's sign, which is softening of the uterine isthmus. Make sure that you're familiar with this. Chadwick's and Heger's are found in pregnancy. They'll have Goodale's sign, which is softening of the cervix. Braxton Hicks, which are contractions, and then you'll hear fetal hard tones. Diagnosis of a pregnancy, you're going to start with the beta HCG, right? And then you confirm with an ultrasound. It's the most accurate to detect fetal size. So how do you confirm pregnancy on your initial office visit for these patients? So how do you confirm an estimated date of delivery? So we have Nagel's rule. Make sure that you are familiar with this, because I can guarantee you're going to get a question where you have to estimate the delivery date. So Nagel's rule is last normal menstrual period plus 7 days minus 3 months. Okay, so the last normal menstrual period plus 7 days minus 3 months. On the initial office visit, you're also going to do a sonogram, and you're going to basically look at the crown rump length and then the biparietal diameter. And then you're going to do a complete pelvic exam. You're going to estimate the uterine size. You're going to do a pap smear to culture for any type of STD like gonorrhea and chlamydia. Labs, you're going to do a CBC, a blood type, an RH status, a urine analysis to make sure that the patient does not have some type of UTI, because any type of asymptomatic bacteria you find in a urinalysis, you have to treat in pregnancy, okay? Because you can consider them as immunocompromised, so that's why you want to make sure that you do this. You're going to do RPR to rule out syphilis, rubella titer, TB skin tests, HIV and HBV antibodies. You're going to do a TSH level, because hypothyroid patients need to increase their synthroid, because mothers that are not treated for their hypothyroidism can have babies or newborns with cretinism, which is a severe form of hypothyroidism in newborns, and this causes mental retardation. They'll have that tongue protrusion, so that's why you want to make sure that you treat hypothyroid in pregnant women and you increase their synthroid or their levothyroxine. Weight gain, so women tend to gain about 25 to 35 pounds, and then after that, it's going to be half a pound for the first 28 weeks, and then 1 pound after the 28 weeks until delivery. Okay. You want to do genetic counseling. You want to look at their folate and iron, make sure they're not anemic, give them some multivitamin supplementation, and then also give them their influenza vaccine. So how are you going to estimate gestational age by uterine size? Okay. At 12 weeks, you'll be able to estimate it at the pubic symphysis. At 16 weeks, it will be midway from the pubic symphysis to the umbilicus. At 20 weeks, it will be at the umbilicus. And then at 20 to 36 week, height in centimeters above the pubic symphysis, it correlates with the weeks of gestation. So just make sure you know this. I had a question on this. 20 weeks is the most common one I kept getting asked. 20 weeks, it'll be at umbilicus, okay? And then 12 weeks at pubic symphysis. So what exams are we going to do for the first trimester? So on the first trimester, you want to visit every 4 weeks. You want to evaluate for any weight gain or loss. You want to take their blood pressure, look for any pedal edema, do the fundal height, right, like we discussed. You want to do a urine dipstick to look for any glucosuria or proteinuria. And then on your second trimester, there's going to be a visit every 4 weeks. From 15 to 18 weeks, you want to offer the triple marker screen, okay? You want to do a beta HCG, estriol. You want to do You want to do an alpha fetoprotein test. This is going to be used to detect neural tube defects like Down syndrome. Okay, this is at 15 to 18 weeks. At 16 to 20 weeks, you can do an amniocentesis if the woman wants it, especially if the woman is older than 35 years old, because you want to diagnose any chromosomal abnormalities. At 17 weeks, you want to document any movement. At 24 weeks, guys, this is high yield. Make sure you know this. What are you going to do in a visit at 24 weeks? You're going to do glucose screening, okay? You want to make sure that they don't have any gestational diabetes mellitus. And this is going to be done with a 1-hour glucose challenge test. So if it asks you when can this patient come in for their glucose testing, it's going to be at 24 weeks. And then at 25 to 28 weeks, you can repeat their hematocrit level. So third trimester, this is going to be a visit every 4 weeks until 28 weeks, and then every 2 weeks until 36 weeks. And then after that, every week. In third trimester, you're going to look at their urine glucose or blood glucose. You're going to ask about any preterm labor symptoms, like if they're having any vaginal bleeding, any contractions, if they've had any rupture of membranes. At 28 to 30 weeks, you're going to give ROGAM if indicated, okay? At 28 to 32 weeks, a woman that has pregestational diabetes mellitus should also have a non-stress test twice weekly until they have labor and delivery. And then at 35 to 37 weeks, you want to screen for group B strep. And then at 36 to 40 weeks, you want to do gonorrhea and chlamydia cultures if needed. And then at 41 weeks, you're going to offer induction of labor, okay? So now we're going to go into multiple gestations, right? So this is a high-risk pregnancy. It's about 1% of pregnancies. Basically, the cause is going to be monozygotic, right? If you have a divided ovum, it's going to be identical twins. If you have a dizygotic ovum, then it's going to be 2 separate ova that are fertilized by 2 separate sperm, and then you're going to have fraternal twins. Some of the complications for multiple gestations is going to be anemia, hydramnios, which is basically excessive amniotic fluid, eclampsia, preterm labor, atony or hemorrhage, C-section risk, nausea and vomiting. Some of the complications for the fetus is going to be congenital abnormalities, spontaneous abortion, premature rupture of membranes, prematurity, umbilical cord prolapse, placental abruption, placenta previa, malpresentation. So instead of the baby presenting in the normal way that they should, they're going to be presented abnormally. And how are you going to diagnose this? You're going to, of course, do the beta ECG, which is going to be positive, but you're going to confirm with an ultrasound, and you'll see multiple gestational sacs, also known as a twin peak sign. So now we're going to discuss the fetal position. So normal position and presentation is facing backward and the head first. So the head first, down, baby's facing backwards. It's also known as an anterior occipiocephalic. And the lie, how they're going to be lying, it's going to be longitudinal. This is ideal. If it's transverse, it's not ideal, and basically they're perpendicular. And then oblique, it's not ideal at all. It's going to be on an angle. So the best lie position is going to be longitudinal. Presentation, part of the fetus is going to be lying over the inlet of the pelvic or cervical os. Basically, you're able to palpate this or visualize this, right? Cephalic position on presentation is going to be her head first. Vertex with flexion of head is the most optimal. Breech is going to be the buttock or foot first, and then transverse is going to be the shoulder first, okay? Brow is going to be the head first, but in neck extension. Position is going to be relation of point, a reference to one of 8 octines of the pelvic inlet. Engagement occurs when biparietal diameter, fetal diameter, is at or below the inlet of the true pelvis, so it's descending. Attitude is way that the body is flexed. Normal is fully flexed, so it's basically a chin to their chest, rounded back in their flexed arms and legs. Station is presenting part to the level of the ischial spines, right? Measured in plus or minus centimeters, so whether it's -5 or +5, and it's going to be measured on the ischial spine. Station 0 is engagement. And then you have dystocia, which is difficult labor or childbirth. This is associated with abnormalities of the pelvic, fetus, uterus, or cervix. And then mucus plug is formed during pregnancy by estrogen. It creates a barrier for things like bacteria from entering cervix. So that's why the woman has a mucus plug. which basically is that barrier from bacteria entering the cervix. Okay, so like we said, there's a station, and this is how you're going to tell whether the baby's floating, they're engaged, or they're crowning. Okay, so you're going to measure this. You have the pelvis, right, and then you have the pubic symphysis. At 0, they're going to be at the ischial spine. And then at +5, which is basically crowning, they're going to be at the ischial tuberosity. And then at -5, they're going to be floating. Make sure that you look at photos of this. If you're a visual person, that's what I did. So now we're going to go into the labor and delivery. Okay, so your true labor, that's when the patient is having regular, painful, consistent contractions. They've lost that mucus plug. They've had that rupture of membranes, which is when the water breaks. And then they'll have regular contractions until the cervix is dilating more and it's effacing more. So with dilation, it's a gradual opening of the cervix, and it's measured in centimeters from 0 to 10 centimeters. So basically how much that little cervix dilates. And it can go from 1 centimeter, 3 centimeters, 6 centimeters, 7 centimeters, 8 centimeters, 9 centimeters, 10 centimeters. I remember being with my OB-GYN doctor, and if there was a patient that was in labor, we were waiting for that cervix to dilate. So we were waiting, and he would go in there and check and check and check and check until that cervix was dilated so that baby can be born. And then effacement is a gradual thinning and shortening and drawing up of the cervix, measured in percentage from 0 to 100. So also in labor and delivery, there's going to be green and smelly. This is going to be meconium. It's the first poo that the baby has. And usually with this is a risk of aspiration, and this can cause fetal distress. Also, you're going to do the nitrazine test, and this is going to turn blue. Usually when a woman comes and they say that they're in labor, they can have premature rupture of membranes, and this is how you tell whether the patient is truly in labor, is by this nitrazine test. It has to turn blue. And when it turns blue, it means it's positive for leaking amniotic fluid, and the patient is actually in true labor. So artificial rupture also, basically you do that by an amniotomy. Basically you induce labor. Done with weak contractions where amniotic sac is still intact. And this tends to be contraindicated in babies that are in breech position or in placenta previa. So I'm going to discuss now the different types of labor. Honestly, I found this very confusing, so I'm going to be as, hopefully I do not make it as confusing for you guys. So we have the first stage of labor, which is basically onset of labor until complete dilation of the cervix. So remember we were talking about the dilation. Complete dilation of the cervix is 10 centimeters. So if you have to wait for that dilation, then you have to wait. But onset of labor is until there's a complete dilation of that cervix, and then the effacement is 100%. This is the longest stage of labor. Patient may lie down, but not supine. You want to make sure that you're checking their fetal monitoring, their uterine activity, and doing a vaginal exam. Okay, and then you have different stages. So you have your latent or early stage. Basically, the patient's going to be at 0 to 3 centimeters dilated. They'll have irregular contractions every 5 to 30 minutes, lasting about 30 seconds. And then the effacement is going to be between 0 to 30%. This takes about 20 hours. So remember we discussed that at full 10 centimeters of dilation, that's full labor, and then at 100% for effacement, that's full labor. Well, with the first stage, okay, like we discussed, with latent stage, which is the early stage, there's only going to be 0 to 3 centimeters of dilation, not the full 10 centimeters. It's going to be 0 to 3 centimeters dilated. Make sure you know this because you'll have a question and it'll tell you how much the patient has dilated and how much they have effaced. And you have to make sure to know that whether it's the first labor, the second labor, whether it's the early stage of the first labor or the active stage of the first labor. And this is how you know that, okay? So 0 to 3 centimeters dilation is early stage, also known as latent stage, and 0 to 30% also effacement is latent stage or early stage. And then we have the active stage. This is more than 4 centimeters dilated, and then it can efface to 100%. Basically, the patient is going to have intense regular contractions, 60 to 90 minutes duration with 30 seconds to 2 minutes in between. So this lasts about 4 to 8 hours. There's going to be crowning where cervix is fully 10 centimeters dilated, and you can see sometimes the head of the baby coming down. Okay, So basically the active stage is anything from 4 centimeters to the 10 centimeters, okay? And then we have the early stage, which is less than 3 centimeters dilation. And effacement in active stage is 100 centimeters. Okay. And then we have protracted cervical dilation, which is basically a slowly progression of dilation or weaker contractions, and you treat this with oxytocin. Okay, so if the patient's taking a while to dilate, okay, like there will be cases with my OB-GYN where the patient just took forever to dilate, then you can give them oxytocin. This is going to help the patient dilate their cervix. And then we have the second stage of labor. This is a complete dilation of the cervix. So the cervix is already dilated. It's at 10 centimeters dilated. It's effaced at 100%. And it's from the complete dilation until the birth of the baby. So this is a pushing stage. Okay? It takes about 1 to 3 hours for first-time mothers, and then 20 minutes for mothers that have already had children. So there's 3 P's. There's your power, which is your forceful contractions, your passenger, which is a fetus, and then your passage, which is a route through the bony pelvis. Okay. If there are no fetal heart rate or contractions seen, then you're going to do an emergency section. So now we're going to go into the third stage of labor. It's from birth of the baby until delivery of the placenta. You can do a uterine massage to promote uterine contraction. So uterine contracts so placenta separates from the uterine wall. You want to carefully remove so no placenta remnants are left in the uterus. And then you have the fourth stage of labor, which is from delivery of placenta until the patient is stabilized. You want to monitor their vital signs, if there's any bleeding or infection. We want to make sure that we are monitoring the fetal heart tone. So baseline fetal heart tone, normal baseline is between 110 to 160 beats per minute. Where the heart rate tends to hover, you want to exclude that there's any accelerations or decelerations. Bradycardia is basically anything that's less than 110 beats per minute. Usually it's normal in fetal sleep. And then tachycardia is anything that's greater than 160 beats per minute. These are for fetuses, okay? Usually this is used to stress or anxiety, fever, infection, placenta abrupta, anemia, blood loss, and medications that the mother may be taking. So then there's a variability, which is a fluctuation of baseline in amplitude and frequency. It's not a straight line. It basically moves up and down. Make sure that you know how to read this because you'll have a question. If it's absent, you aren't able to detect any type of variability. It's a straight, smooth line. If it's low, it's a change of less than 5 beats per minute from the baseline. If it's moderate, it's a change of 6 to 25 beats per minute from baseline. This is usually reassuring and it's very common. And the most common one. And then you have a marked variability, which is a change of more than 25 beats per minute from baseline. And this is usually with fetal hypoxia, so the fetus isn't getting any oxygen. So this is why you want to make sure that you're monitoring the variability. And then you have your accelerations and decelerations. So an acceleration is a periodic increase in fetal heart tone of 15 beats per minute sustained for at least 15 seconds. So 15 beats per minute sustained for at least 15 seconds. This is an acceleration. Make sure you know that. Also known as 15 by 15, and this is reassuring. It means that the baby's moving, right? And it's being stimulated. And then you have a deceleration, which is a drop in fetal heart tone of more than 15 beats per minute within greater or equal to 30-second duration. There's different types. You have your early, your late, and your variable deceleration. So in your early deceleration, the baby heart rate decreases at the same time as a mom's contraction. So it coincides with the contractions. It's basically a mirror, okay? Or also vagostimulation. Some of the causes of this is compression of the baby's head on the pelvis or soft tissue. It tends to be normal, so you really don't have to do anything with this. So make sure you know also how these present. You'll get a patient that has an early deceleration. You have to know that this is normal. It's nothing you have to worry about. And it's due to compression of the baby's head on the pelvis or the soft tissue. And then you have your late decelerations, which is the baby's heart rate that declines after the contraction ends. It's a heart rate response after contraction, and then you'll usually say a delayed U shape. Okay? Usually the causes of this, it's a uteroplacental insufficiency, so that's how I memorize it. Uteroplacental U, that's how it's going to look. Basically the baby is not getting enough nutrients or oxygen. And then there's variable, it's not uniform. Baby's heart is responding at different time. It's basically all over the place, it's scattered. And this is going to be V-shaped. It's abrupt. So V-shaped, variable, For late, it's going to be U-shaped due to uteroplacental insufficiency. For variable, it's going to be due to cord compression. This is an emergency. You have to do something, okay? So drugs that are used during labor and delivery, you'll definitely have a question about this. You have your cytotec, also known as misoprostol. It's a prostaglandin. It induces labor and cervical ripening. So with this medication, if it asks you a question, what would you use for cervical ripening, then you would use something like misoprostol, right? You want to make sure with this one you wait more than 4 hours before you use the use of oxytocin. And then you have your Pitocin or oxytocin. This helps in labor induction or augmentation and postpartum hemorrhage prevention in a patient that has uterine atony, so the treatment for uterine atony. For pain, you want to give them opioids like Demerol. And if fetus is in distress with Demerol, you can give something like naloxone. You can also give magnesium sulfate, which prevents seizures, or terbutaline with lungs. So magnesium sulfate, make sure you know that it's for seizures. If a woman has eclampsia, magnesium sulfate. And then epidural and anesthesia for lower half of the body, you want to give it earliest at the first stage of labor when the mother's dilated to 2 centimeters. So lactation. Suckling, it stimulates sensory nerves per prolactin and oxytocin release. During pregnancy, estrogen helps breast tissue prepare for lactation. And then you have prolactin that promotes lactation and maintains it once it's established. Prolactin decreases FSH and LH, so it inhibits reproductive function. So that's why most of this women don't have periods, right? And then we have oxytocin. Women that are pregnant do not. Once they have the baby, they do not have periods when they're lactating. And then we have oxytocin. It promotes milk letdown, and it promotes contractions in labor and delivery. Make sure that you know that. I had a question on this. Okay, if it asks you what hormone is responsible for promoting milk letdown, it's going to be oxytocin. So make sure that you know that. And then suckling, so the baby suckling tends to stimulate the sensory nerves for prolactin and oxytocin release. Okay. So prolactin, once again, it promotes lactation and maintains it. Oxytocin promotes milk letdown. So now we're going to go into pregnancy complications. So let's start off with spontaneous abortion, which is also known as a miscarriage. It's a non-elective termination of a pregnancy before 20 weeks. It's the most common complication of pregnancy in a woman that's less than 20 weeks pregnant. Some of the causes is that it increases with an advanced maternal age. Most of these spontaneous abortions are in first trimester, and they tend to occur before the 8th week. And recurrence is likely, especially if the patient has already had a previous spontaneous abortion. And risk tends to decline as the pregnancy progresses. So if it's in the first trimester, the most common cause is going to be chromosomal. Make sure you know that. Second trimester, it's going to be an abnormal karyotype, low progesterone, motor vehicle accident, so some type of fall. Risk factors for a spontaneous abortion is advanced maternal age, like I said, incompatibilities like ABO or RH, so the baby's blood is different than the mother's blood. Teratogens, so drugs, medications that the patient might be taking, certain antipsychotics, alcohol, radiation, nicotine, mercury, uterine abnormalities like fibroids or leiomyomas, maternal infections like listeria, herpes simplex virus, cytomegalovirus. If they have an incontinent cervix, this is where you have to go and do the circlage, right? Diabetes mellitus, if the patient has systemic lupus erythematosus, SLE, guys. Basically, patients that have SLE are more prone to have hypercoagulabilities, so this can make them more prone to having abortions. Obesity, if they have polycystic ovarian syndrome or hypertension. Signs and symptoms of a spontaneous abortion, it's going to be vaginal bleeding or discharge. They'll be passing clots. They'll have some abdominal pain and cramping. And there's different types, and make sure you know the difference between these spontaneous abortions. You have threatened, missed, inevitable, incomplete, completed, and septic. Okay. How I memorized it was TIIC, MTIIC. Basically, MTI, you're going to have a dilated cervix, and then your IC, your complete and your completed, it's going to be a closed cervix. Basically, how I memorize these is that eyes open, so anything that starts with an I, you'll have a dilated cervix, okay? If it doesn't start with an I, the cervix is not dilated. So let's start with threaten. Threaten is the most common one. It's very common. It's normal. You'll basically have a normal ultrasound with minimal bleeding and no cervical dilation and no passage of product of conception. So make sure you know that, how to differentiate these, whether there is cervical dilation or not, and whether there is passage of product of conception or not. So like I said, eyes open, right? Your eyes open, and that's how I memorized it, that the cervix is going to be open or dilated. So next one's going to be missed. It's going to be an abnormal ultrasound with no bleeding and no cervical dilation. Versus threatened, right? This is a normal ultrasound. With threatened, most of these babies, pregnancies tend to go on and be well. And then we have our inevitable. So inevitable is an abnormal ultrasound with bleeding. They have a dilated cervix, but they have no passage of product of conception. So like I said, remember, eyes are open. Inevitable, eyes are open. You have a dilated cervix, no passage of product conception. You have incomplete, which is an abnormal ultrasound with bleeding, dilated cervix, loss of some but not all product of conception. So this is an eye also. So this is eyes are open, dilated cervix. And then you have your completed, which is a closed cervix. Ultrasound shows empty uterus, and uterus is contracted. And then you have the septic one, which is basically an infection of the uterus during miscarriage. The patient will have fever, chills. The most common infection is Staph aureus. And then there'll be a dilated cervix with purulent discharge, and then the patient will have uterine tenderness. Diagnosis is going to be with an ultrasound. Basically, on an ultrasound, you'll see no fetal hard tones. There'll sometimes be an abscess of product conception, right, depending on which type of spontaneous abortion there is. And you want to also estimate the location of the pregnancy, whether it's ectopic or intrauterine. You want to estimate the expulsion of the product conception, whether it's partial or complete. Labs you want to do a CBC, serum beta HCG, which is normal in first trimester. It doubles every 48 hours. So if it's abnormal, then you'll want to think about maybe an abortion's going on. You also want to do a serum progesterone. If it's greater than 25, it's normal. If it's less than 5, it's non-viable gestation, right? Because what did we say? Progesterone is progestation. Also, you want to do a blood type and RH if they're losing a lot of blood, a urine analysis, culture. You want to do a blood culture for septic abortions. Screening, you can do this with a chorionic villus sampling, which is done at 10 to 14 weeks, as we described earlier. It's a genetic analysis for placental sample, looking for any type of genetic problems that can occur, right? And then you also do an amniocentesis. So at week 15, basically you also look at the sample of the fluid. And treatment's basically observation for the ones that are threatened, complete, and inevitable. For surgical evacuation, this is going to be for missed, and then emergency surgical evacuation is going to be for inevitable or incomplete. Surgery basically is suction curettage, which is done in the first trimester, or a DNE, which is dilation and evacuation, in second trimester. So first trimester, suction curettage. Second trimester, dilation and evacuation. You can also give medications like a misoprostol. And then you're also going to give RhoGAM when a mother is Rh negative and the father is Rh positive or is unknown, usually about 50 micrograms. So now we're going to go into ectopic pregnancy. Basically, this is a pregnancy that's located outside of the uterus. There's not enough space or blood supply to support a normal pregnancy. The most common is a tubule or ampulla. Some of the causes are tubule factors, zygote abnormalities, ovarian factors, exogenous hormones, low blood supply to the embryo. Risk factors is if a woman had a prior ectopic pregnancy, they're more likely to have another one. If they have pelvic inflammatory disease, if they had an AUD, or if they have an IUD, smoking, abdominal surgery history, surgery to the fallopian tubes, endometriosis. Symptoms, you'll have your vaginal bleeding, your abdominal pain, your amenorrhea, pelvic pain, adnexal masses, nausea and vomiting, dizziness, shoulder pain. You're going to confirm this with a transvaginal ultrasound. You're also going to do a beta HCG. The beta HCG is going to have prolonged doubling time. Basically, it doubles every 2 days, and this is going to tell you that there's an intrauterine pregnancy. You're also going to do a CBC, a CMP, UA, blood type, and RH. If the patient's stable, the treatment's going to be monitoring the serial beta HCG. Or you can later give a methotrexate to terminate the pregnancy. So why are you monitoring the beta HCG? You want to make sure that it's going down, okay? And then methotrexate to terminate the pregnancy. If the patient's unstable, if they're hypotensive, they're tachycardic, this is going to be emergency. If it's ruptured, if there's a massive hemorrhage, then you're going to do a laparoscopy. And this is usually a salpingostomy or an ectomy, salpingectomy. So next one we have is gestational diabetes mellitus. You'll have a lot of questions with that. It's really common in the valley where I was rotating at. A lot of our patients had gestational diabetes. And basically, what is it? It's glucose intolerance or diabetes mellitus first recognized during pregnancy. Okay, so they become diabetic when they're pregnant. It's the #1 medical complication of pregnancy. It's due to released human placental lactogen, which antagonizes insulin, and it tends to worsen as the placenta enlarges. They tend to have more of this human placental lactogen as the placenta is enlarging. Risk factors: if they had a history of gestational diabetes mellitus in previous pregnancy, if they're obese, if they have a history of abortions, PCOS, family history of diabetes mellitus, if they have an advanced maternal age. Some of the symptoms is that it's going to be macrosomia, so the baby's going to be really, really big. That's why you have these really big babies, usually from mothers that have gestational diabetes that is not controlled. They'll also have a large head. These patients will have a large head. They'll have basically the symptoms of diabetes, right? Your polyuria or polydipsia, your polyphagia, they'll have paresthesias. So screening for gestational diabetes, remember we discussed this earlier, it's done at 24 weeks. So 24 to 28 weeks, you want to screen these patients for gestational diabetes. You basically want to do initial is going to be 1 hour 50 gram glucose tolerance test. Make sure you know this. So 1 hour 50 gram glucose tolerance test is going to be the initial one. If it's more than 130 at 1 hour, you want to suspect gestational diabetes mellitus. It's very sensitive. If it's negative, then you can rule out gestational diabetes mellitus. And then you're going to confirm with the 3 hour 100 glucose tolerance test. It's basically if it's greater than 180 at 1 hour, then it's positive. If it's greater than 155 at 2 hours, it's positive. If it's greater than 140 at 3 hours, it's positive. This one's very specific. So if this one's positive, then you're going to rule it in. So make sure that if it asks you which one of these is a diagnostic test to confirm that they have it, it's going to be the 3 hour 100 gram glucose tolerance test. Make sure you know how it's going to present also. That if it's greater than 180 at 1 hour, it's positive. If it's greater than 155 at 2 hours, it's positive. If it's greater than 140 at 3 hours, it's positive. Treatment's going to be lifestyle changes, right? You're going to tell them to have strict diet, control the glucose, and you can also give them metformin. It's very safe in pregnancy, and metformin is usually the #1 treatment for diabetes mellitus too, right? You can also give insulin. Insulin's actually a lot better than metformin. It depends on the patient. Labor and delivery is going to be determined by the fetal weight. You want to consider C-section if the baby's really big, right? If they're greater than 9 pounds, this is what macrosomia is, these really, really big babies. Some of the maternal complications is that the mother has a higher likelihood of developing type 2 diabetes mellitus later in life. They have an increased risk of hypertension, preeclampsia, eclampsia, polyhydramnios, infections, and UTIs. What are the complications for the baby, the fetus? They can have preterm labor. They can have a lot of congenital malformations like limb deformities, neural tube defects, cardiac abnormalities, and then of course your famous macrosomia, which we talked about earlier. So now we're going to go into pregnancy-induced hypertension. Basically, it's gestational hypertension after 20 weeks of gestation. Okay, so it has to be after 20 weeks of gestation that the pregnancy caused this hypertension that the patient is experiencing. Chronic hypertension is basically a history of elevated blood pressure before pregnancy or 20 weeks. So if there's a woman that presents and they have a hypertension and it's been less than 20 weeks, then you can say it's chronic hypertension and it's not caused by the pregnancy. Or if they had a history of elevated blood pressure before pregnancy, then it's not pregnancy-induced. Versus if they have hypertension after 20 weeks of gestation, it's just gestational hypertension. So some of the causes is if the patient usually is an African American, if they have a family history of pregnancy-induced hypertension, if they have multiple gestations like twins, if they're in advanced maternal age, diabetes mellitus, if they're obese. Symptoms is that they're usually asymptomatic. They can't complain of headaches in the morning, dizziness, blurred vision, fatigue. And with these patients, they only have hypertension. They have no signs of preeclampsia, okay? We'll go into preeclampsia and eclampsia in a few minutes. Diagnosis is that their blood pressure is going to be greater than 140/90 after 20 weeks of gestation. They'll have elevated blood pressure on 2 separate occasions, at least 4 hours apart. It has to be 2 separate occasions. Treatment, you're going to basically monitor their blood pressure. If you do have to be given medications, you give them labetalol, hydralazine, nifedipine. These are safe in pregnancy. And they tend to return to baseline after 6 weeks postpartum. So now we're going to go into preeclampsia. Basically, it's gestational hypertension that we just discussed, plus proteinuria, so protein in their urine after 20 weeks. It tends to involve a lot of organs like kidneys, your livers, and lungs. Etiology, nulliparity, so if a woman has not had children in the past, if they have a family history of preeclampsia, African American, if they have multiple gestations like twins, advanced maternal age, if they're obese, history of gestational diabetes mellitus or just diabetes mellitus in general. Symptoms, it's going to be similar to your regular gestational diabetes, which is going to be your nulliparity, your family history, they're African American. The symptoms for this, they're going to be asymptomatic. They could be complaining of a headache. This is going to be big, so any patient complaining of a headache, you want to make sure that you rule it out. Dizziness, blurred vision, weight gain and water retention, right upper quadrant pain, edema of the face and the extremities. Hyperreflexia, proteinuria is a big one. Diagnosis is going to be their blood pressure is going to be greater than 140/90. You want to do a urine analysis where you'll see 1 to 2 plus proteinuria, a protein creatinine ratio greater than 0.3. And then on serology, you'll see thrombocytopenia, hyperuricemia, and hemoconcentration. So basically, patient's going to be complaining of a headache. They're going to have some peripheral edema, right? And then the woman is also going to have some protein in their urine, and then that's when you know it's preeclampsia. Definitive is going to be delivery for the treatment. So if they ask you what is a definitive treatment, it's going to be delivery. You want to deliver the baby. Other treatment is monitoring, bed rest, medications for your hypertension. You want to get it under control. You want to give them labetalol, hydralazine, nifedipine. For preeclampsia prophylaxis, you can give them aspirin, 81 milligrams orally once a day. Prevention of eclampsia. So you want to prevent the patient from going from preeclampsia to eclampsia. You can give them IV magnesium sulfate plus diazepam. And then there's also HELLP syndrome, which is also something very, very severe. It's life-threatening. HELLP syndrome can develop in pregnant women. Basically, they're going to have preeclampsia, hemolysis, elevated LFTs, and low platelets, so thrombocytopenia. If they have any of these symptoms, it's going to be HELLP syndrome. So now we're going to go into eclampsia. Basically, preeclampsia can develop into eclampsia. Most of these cases occur in intrapartum and postpartum period. So it'll be preeclampsia plus seizures, new onset of seizures. Once again, it's common in women that are African American, if they have multiple gestations, advanced maternal age, diabetes mellitus. Symptoms, they may or may not complain of a headache. They'll have dizziness, blurred vision, weight gain and water retention, abdominal pain, edema, hyperreflexia, and seizures and altered mental status. So this is how you're going to differentiate between eclampsia and preeclampsia, is that in eclampsia, the patient's already developing seizures. So diagnosis, basically, like I said, preeclampsia, nuanced seizures, or have the generalized tonic-clonic grand mal seizures. Treatment first line is you're going to give him IV magnesium sulfate plus diazepam. You want to control those seizures, right? So make sure that you know that first line, IV magnesium plus diazepam. You want to make sure that to look out for any magnesium toxicity. This is usually shown by the patient having hyperreflexia and bradyapnea. And if they do have magnesium toxicity, then you want to give calcium gluconate. And once again, the definitive treatment is going to be delivery. So if you have a patient, they're having eclampsia and they're on IV magnesium sulfate and they're having their breathing is very slow, they're being hyperreflexic, then you want to consider magnesium toxicity, and then you give them calcium gluconate. So make sure you know that I had a question on this. So now we're going to go into placenta previa. So placenta previa is basically placenta that is implanted low in the uterus within the zone of dilation and effacement. It's the most common cause of third trimester bleeding, and it typically happens after 20 weeks. So placenta previa will not present in a woman that is less than 20 weeks. It's more commonly found in women that are already in their third trimester. Causes, if the patient had a prior C-section, that's one of the big ones. If they've had several births, advanced maternal age, if they have a large placenta, And symptoms, it's going to be they have a sudden, painless vaginal bleeding. So this is what's going to separate it from placenta abrupta, is that placenta abrupta is going to have painful bleeding. Placenta previa is going to have painless bleeding. Okay? They may or may not have uterine contractions, and usually the baby is not in any fetal distress. Diagnosis is going to be a pelvic ultrasound. If it's low-lying or marginal, the placenta is low-lying or marginal, you'll see it within 2 centimeters. If it's partial, it'll be partially covering the cervical os. If it's complete, it'll completely cover the cervical os. Contraindications is a pelvic exam, and this is because you can cause placental disruption and the bleeding can worsen. Treatment is usually expectant and C-section delivery if it's more than 36 weeks and they're having a lot of blood loss, if they're having coagulopathies and there's fetal distress, and you want to do also blood transfusion and IV fluids. If they're preterm, okay, then you're going to do bed rest, tocolytics like magnesium sulfate, amniocentesis to check the fetal lung maturity, and corticosteroids to enhance lung development. So if it's preterm and this patient is presenting with placenta previa, you just make sure that you observe them. Okay, you tell them to take it easy because you do not want to deliver. You want to deliver until the patient is at term. If the patient is at term, then you would do a C-section. So basically if they're greater than 36 weeks. So now we're going to go into placenta abrupta. Basically, it's a separation of placenta from the site of uterine implantation before the delivery of the fetus. The most common cause of third trimester bleeding. And this is an emergency. Versus placenta previa, I would say it's an urgency. This one is an emergency. Some of the causes, it's going to be your trauma or motor vehicle accidents. If you've seen those movies of pregnant women that like fell and then they're like bleeding a lot, it may be placenta abrupta. That's how I memorize it. Also, if the patient has a history of smoking, smoking's huge. Make sure you know that smoking and hypertension are common and associated with placenta abrupta. If they have a history of preeclampsia, premature rupture of membranes, multiparity, if they have prior history of placenta abrupta, okay, if they drink alcohol, but the big one's going to be smoking, hypertension, trauma, and motor vehicle accidents for placenta abrupta. The huge one I kept seeing was cocaine use. So it was a woman that had the symptoms of placenta abrupta and it asked you what drug use. Cocaine use is a big one for this one also. Signs and symptoms: painful vaginal bleeding, like I said, abdominal pain, back pain, gravid hypertonic uterus, hypotensive, tachycardic, contractions, fetal distress. Diagnosis is going to be with a pelvic ultrasound. And you're also going to do a CBC and a PT and PTT. You're going to look at their fibrinogen levels, blood types, and RH status. If they're stable and it's less than 34 weeks, then I would do expectant management with continuous fetal monitoring. If it's greater than 36 weeks, then you can do an amniotomy, so induce. If they're unstable and you see that the fetus is in distress and the mother is hemodynamically unstable, then you're going to do operation and immediate delivery via C-section. So RH incompatibility, that's when the mother's RH negative and they're carrying a baby that is RH positive at delivery. Usually this causes ectopic pregnancy, abortions, and like I said, so the mother's going to be, the RH negative mother's going to be, the mother's going to be RH negative, the father's going to be RH positive. And also there may be some maternal exposure to fetal blood, so whether it's through the delivery, amniocentesis, abortion, or ectopic. Okay. And then on second pregnancy, so there's going to be antibodies, IgGs across the placenta, and they cause hemolysis to the fetus. So the baby's going to be suffering from fetal anemia, ascites, edema, congestive heart failure, and hydrops fetalis. So diagnosis, you're going to do a blood type, ABO, and an RH screen of the mother. So if the mother is RH positive, you need no further screening. If the mother is RH negative, then you're going to screen for anti-D antibodies. And then for prenatal, you're going to do an ultrasound to see if there's any hydrops fetalis, and then an amniocentesis. If it's postnatal, you're going to do a positive Coombs test, right? So what does a positive Coombs test tell you? If there's any antibodies that are on the blood cells that may be causing the baby or the newborn to be anemic, causing hemolysis. Treatment's going to be with RhoGAM 300 micrograms, okay, at 28 weeks within 72 hours of delivery. So treatment for RH incompatibility, you're going to do RhoGAM 300 milligrams at 28 weeks and within 72 hours of delivery. And also give them iron supplementation. So now we're going to go over gestational trophoblastic disease. This is basically an abnormal fertilization of the ovum. Okay. You have different forms. So you have your hydatiformals. These are benign. And then you have your malignant ones, which are invasive. And examples of this are invasive and choriocarcinoma. So there's three types. You have your partial hydatiformal, your complete hydatiformal, and then your invasive malignant choriocarcinoma. Partial hydatiformal, just know that it's going to be presented as 69XXX or 69XXY or 69XYY, okay? Basically, it's going to be a normal ovum that is being fertilized by 2 sperm. And then we have our complete hydatiforms, which is 46XX, 46XY. It's going to be an empty ovum that's fertilized by a single sperm. They have paternal genetic duplication, 50 to 20% with chorionic villi. And then you have your invasive moles. These grow into the muscular wall of the uterus and it tends to be formed after conception. And then you have your choriocarcinoma, which originates in the placenta and it has a potential to invade the uterus and metastasize. It's very aggressive. So the choriocarcinomas are the worst ones. Some of the risk factors are extremes of maternal reproductive age. So if the mother is less than 15 or the mother is greater than 35 years old, they're more likely to get these. If they had a prior history of molar pregnancy or the history of miscarriages. Symptoms, so hyperemesis gravidum is usually pathognomonic for gestational trophoblastic disease or any type of molar pregnancy. So make sure that you know that. If it's a woman, she's complaining of hyperemesis gravidum, then you want to make sure you have in your differential diagnosis some type of mole or gestational trophoblastic disease. The woman's also going to be complaining of vaginal bleeding and enlarged uterus, which is greater than normal, okay? So say they're at 20 weeks and it looks like they're already at 38 weeks. That's abnormal. Pelvic discomfort, pain, and pressure. So diagnostic tools, initially you're going to do a beta ECG. It's going to be increased, usually in complete versus partial hydatiformal. So it's going to be a lot more increased in complete. You also do a chest x-ray to see if there's any lung metastasis, if the patient is complaining of chest pain or trouble breathing. You're going to do a transvaginal ultrasound. Complete will show you basically a snowstorm, cluster of grapes, or honeycombs pattern, okay? So a complete hydatiformal, once again, pathognomonic, snowstorm, cluster of grapes, or honeycomb pattern. If it's partial, it'll have fetal parts. Usually they'll show you an ultrasound and you see, and you have to know how it looks on the ultrasound. Treatment is going to be a uterine evacuation. DNC is both diagnostic and treatative. You also do ROGAM for Rh negative mothers. You do serial postmolar beta HCG levels at 8 to 10 weeks. And then chemotherapy, like methotrexate for choriocarcinoma. Continuing on, we are going to go into incompetent cervix, which is basically also known as a cervical insufficiency. Okay, the cervix is basically too weak to stay closed during pregnancy. This results in preterm birth or possible loss of baby. The patient can be complaining of painless dilation of the cervix. And sometimes they can even deliver the fetus between 18 to 32 weeks, okay? So the cervix, like I said, is basically so weak that it's not able to hold the baby anymore. Some of the causes are multiple spontaneous abortions or miscarriages if they had exposure to the drug DES, if they've had repeated cervical dilation, cervical excisional procedures. So treatment for this is going to be basically for a shortened cervix that has no history of any of the things that I just mentioned. It'll be a vaginal progesterone. For a shortened cervix with the previous history, then you're going to do oral progesterone, and then you're also going to do surgical cerclage. So basically you're going to go in there and fix it. So it's a procedure that is used to suture the cervix. You close it until labor. All right, guys, so now we're going to go into labor and delivery complications. So we have the fetal. We're going to start with how you monitor whether the fetus is in distress or not. So you can do a biophysical profile. Basically, it's going to be 5 total measurements for the fetal well-being, and it's each rated on a scale of 0 or 2. You're going to measure the fetal breathing, the gross body movements, the fetal tone, so basically the extremity extension and flexion. You can also measure the amniotic fluid volume. You can also do a non-stress test. I saw a lot of non-stress tests being done in babies. on babies, on pregnant mommies during my OB-GYN rotation. And scoring, if it's 8 to 10, it's something that's reassuring. If it's a score of 6, it's basically equivocal. So you want to do delivery if the patient, the mommy, is greater than 36 weeks. If not, then you want to repeat in 24 hours if the baby is less than 36 weeks. And basically, also, if you have one that's less than 4, this is abnormal and it requires immediate intervention. So next one's going to be monitoring, a non-stress test. Okay, you're going to do a from the top, fetal heart tone. So basically, like we mentioned earlier, normal is 120 to 160 beats per minute. Bradycardia is going to be anything that's less than 120. Sometimes it means it's normal, it means that the baby is sleeping, so the fetus is sleeping. Okay, or sometimes it can mean other things like there's hypotension, poor perfusion, cord prolapse, arrhythmias, medications that the mommy might be taking. And then tachycardia, which is more than 160, sometimes it can be normal, but sometimes it means that there's stress or anxiety. So mommy is very stressed, poor fever or an infection, placenta abrupta. If there's any anemia or blood loss, or also any medications that the mommy would be taking. Okay, so now we're going to go into premature rupture of membranes. Basically, it's a rupture of membranes that has occurred after 37 weeks of gestation prior to start of uterine contractions. Okay, so once again, premature rupture of membranes is a rupture of membranes more than 37 weeks gestation prior to start of uterine contractions. Usually the causes of this is a mother who has a history of premature rupture of membranes, if they have some type of genital tract infection, if they've suffered from antepartum bleeding, smoking. So signs and symptoms, basically the mom's going to show up saying that their water broke. They'll have a slow leak of pale yellow fluid. They won't have any uterine contractions, and their cervical os will be closed. You'll basically see a pulling of fluid in vaginal vault. So make sure that you are familiar with this, with the premature rupture membranes, because you're going to want to know how it's going to present. I had several questions on this. So symptoms, like I said, it's going to be a closed cervical os and pooling of fluid in the vaginal vault. That is high yield. That's something that I kept seeing over and over again. Also, another high yield that you want to know is how do you diagnose this? You're going to have a positive Fern test and then a positive nitrazine test. So basically when you do a pH paper and you put the fluid that the pregnant woman is leaking, the pH paper is going to turn blue. If it turns blue, that means there is amniotic fluid. You can also do an ultrasound, and treatment is that usually this results in delivery within 1 week of the patient having all these symptoms. And if not, then you want to do expectant management. You want to administer betamethasone, so the baby can mature its lungs, right? If the mother is less than 34 weeks, and if the mommy is more than 34 weeks and they're presenting with a premature rupture of membranes, then you can deliver if they're more than 34 weeks. Okay, so now we're going to go with preterm labor. Basically, it's a regular uterine contraction and cervical changes before 37 weeks gestation. Some of the things that the causes of this is basically cervical insufficiency, multiple gestation, smoking, substance use, if the mother is older, so advanced maternal age. Symptoms, it's going to be early onset of regular contractions, premature cervical changes like effacement, dilation, more than 3 centimeters or both. They'll also have symptoms of premature rupture of membranes. Diagnosed preterm labor, you're gonna do it. It's usually a clinical diagnosis, but you can support the diagnosis by doing a cervical ultrasound and also doing a fetal fibronectin test, which is going to be positive. So positive fetal fibronectin test. Treatment, you're gonna do tocolytics because you want to prolong pregnancy, right? Because you want to make sure that the baby is born after, if possible, 37 weeks or 36 weeks, and this patients that come in at 33, 34 weeks with these symptoms, you want to make sure that you prolong their pregnancy. You can also do some antenatal intramuscular steroids. This is going to help once again with the fetal lung maturity. And then magnesium sulfate also. Okay. And then I also wanted to mention the preterm premature rupture of membranes. Basically, this is just time-wise, so the mommy's going to be presenting with premature rupture of membrane symptoms, but it's going to be less than 37 weeks, right? Versus a premature rupture of membranes, it's more than 37 weeks gestation prior to the start of uterine contractions, a preterm premature rupture of membranes is less than 37 weeks. So the 37 weeks is what differentiates preterm premature rupture of membranes and then premature rupture of membranes regularly. Okay, so let's go into breech position. This is basically how the baby is going to present. Make sure that you look at a picture of this because you might have a question on this on your EOR. Some of the causes of breech position is if the mother has multiple gestations, if there's polyhydramnios present, basically there's a lot of fluid in the amniotic. And then hydrocephaly also, anencephaly, uterine abnormalities. There's different types, so there's complete, basically there's flexion of the hips and knees, so the baby's basically like this flex. There's incomplete, which is there's some dorsiflexion of the hip and knee with foot presenting, okay? Basically there's one leg out, and then the baby's like this with their one leg out. And then there's going to be the frank position, which is the most common position, which is going to be flexion of both hips with extension of both knees, okay? So flexion and extension. Frank complete is basically complete flexion of both hips and knees. Incomplete, that makes sense, right? It'll be some dorsiflexion of hip and knee with foot presenting, only a single foot presenting out. So how do you diagnose this? You're going to diagnose this with an ultrasound. Treatment is usually less than 37 weeks. No intervention. If the patient is presenting with over 37 weeks with these things, then you want to definitely observe them and repeat the ultrasound. Okay, prolapsed umbilical cord. This is an emergency. This is an OB emergency. Basically, the umbilical cord descends alongside or beyond the fetal presentation. So it's basically out. And sometimes there can be compression of the cord. And what does compression of the cord cause? This can cause the baby not to get oxygen. So some of the causes of this, it can be placenta previa, macrosomia, so if there's a really big baby, if the baby is just placed in a high station, if the mommy has multiple gestations, history, if the baby's in a breech position, history of premature rupture of membranes, polyhydramnios, if there's a long umbilical cord. So some of the signs and symptoms, it's going to be fetal distress. There's going to be hypoxia with the baby, hypovolemia, because once again, you are compressing the umbilical cord and the baby is having trouble breathing, so you're not getting any oxygen to the baby. Diagnosis is going to be clinical, basically based on the history and physical. And then you're going to do also non-stress test, and you'll see that there will be variable decelerations, because remember we discussed that variable decelerations are usually due to cord compression. This is an emergency. The baby also will be bradycardic. Okay? And treatment, basically, it's digital disengagement. You can also put the mommy in knee to chest position with their hips elevated. This is one of the things that I kept getting questions on, so you make sure you know how to treat this. And then urgency section and oxygen for sure. Okay, so basically you want to, for the treatment, you want to elevate the presenting fetal part to reduce that cord compression, and usually that's what the knee to chest position usually does. And then a C-section if needed. So umbilical cord prolapse, once again, is basically where the umbilical cord presents ahead of the fetus. So now we have shoulder dystocia. It's basically an impaction of anterior shoulder of the baby into the pubis symphysis during vaginal delivery. So as we discussed earlier, right, when a baby's born, they're basically born in a normal pregnancy with their head down. So sometimes when they're born, their shoulder can get stuck when they're when the baby's coming out. And this is what shoulder dystocia is. Some of the causes is obesity, so if the mommy's obese, gestational diabetes mellitus, fetal macrosomia, so once again, if that baby's really, really big. If there is a prolonged second stage of labor, usually also the use of vacuum or forceps. Symptoms, basically you have trouble with extending or rotating the head or retracting the head into the vagina. So basically it'll be that turtle sign, right? Turtle sign where the turtle head out of the shell. Treatment is, you have multiple ways. If it's non-manipulative, you do some suprapubic pressure, and then you flex the maternal hips. This is called McRoberts maneuver. So make sure if you have time to Google those or YouTube them and see how they are performed. So once again, non-manipulative, you have McRoberts maneuver, suprapubic pressure, flexion of maternal hips. You're going to expect this definitely on your exam. Manipulative maneuvers, you have rotation of the fetal shoulders 180 degrees, so it's like a Woods corkscrew, or delivery of the posterior arm verse. And then emergency section, if it's needed, you can do this Zavanelli maneuver, which is you push the head back into the vaginal canal. And then you do a C-section. So now we're going to go into postpartum care. This is the last topic. So normal changes of postpartum care, basically. Period, this is basically a period of 6 weeks after childbirth during which mother's reproductive organs return to non-pregnant condition, okay? So the mommy's organs start coming back normally. Uterine involution, after 1 week postpartum, the uterus should be the size of a 12-week gestational fundus, which is basically palpable at the pubic symphysis, right? Okay. And then we have the lochia rubra, LOCHIA-RUBRA. This is basically normal postpartum discharge, blood, tissue, decidua. Make sure that you're familiar with this because you might have a question telling you that a woman that just had children, they're coming in because they are complaining that they're having some blood or tissue, and this is normal. The cervix tends to gradually close, right? Because the cervix, remember we were talking about it, how much has it effaced? 10 centimeters, that's a lot. You have the cervix and then you have the little hole, that's a lot, 10 centimeters for it to dilate so much and the baby to come out. So the cervix after pregnancy gradually starts closing, 1 centimeter dilated by the end of first week. And then the external os becomes a transverse slit, which is normally what a woman would have that is not pregnant, right? Bladder, its capacity increases. The patient may sometimes have overdistension, incomplete emptying, proteinuria normal 1 to 2 days after delivery. Weight loss, so about 9 pounds average in 6 weeks. And if the patient is at the hospital, you want to make sure that they are ambulating. You want to give them some stool softeners if they're having some constipation. Make sure that they have a good diet. And you want to follow up with them. So some of the things that the patients may be complaining after pregnancy is postpartum hemorrhage, which is significantly blood loss after labor and delivery. It's greater than 500 milliliters of blood loss after vaginal delivery and greater than 1,000 after C-section within 24 hours. So make sure that you are familiar with that. You might have a question. It'll ask you what is significant blood loss in a vaginal delivery versus a C-section. So once again, if it's more than 500 milliliters of blood loss after vaginal delivery, this is bad. And then more than 1,000 milliliters of blood after C-section within 24 hours. What's the most common cause of postpartum hemorrhage? Also make sure that you are familiar with this. The most common cause of postpartum hemorrhage is uterine atony. So basically the lack of uterine tone. Also, the mommy may have some trauma or lacerations or cuts after childbirth, right? There might be some retained placental fragments. If there is, you want to make sure that you get rid of these because they can cause an infection. Coagulopathies also. So signs and symptoms of postpartum hemorrhage is going to be, of course, vaginal bleeding. But the most common sign you'll see is a boggy and large uterus. This is pathognomonic, high yield. Make sure you know this. Boggy and large uterus. And this is due to uterine atony. Diagnosis. Basically, you'll see a decrease in hematocrit. You'll have a change in the mother's heart rate, the blood pressure, their oxygen, and you want to make sure that you're checking the blood pressure to see that they're not becoming hypotensive. They can go into shock because they're losing so much blood. How are you going to treat this? This is an OB emergency. So you want to make sure you do your ABC. So of course your airway, breathing, circulation. You want to give the mommy IV fluids, blood transfusions if needed. And the treatment for atony, since it's the most common cause of postpartum hemorrhage, is you want to do a uterine massage, right? You want to stimulate contractions. You can also give them oxytocin, which will also stimulate contractions. You can also give them something like methylgonavine, which is contraindicated in hypertension, or misoprostol also. Or if it's refractory to all these treatments, then you can do something like a hysterectomy if the mom doesn't want to have any children in the future or you just can't treat it. You can also do ligation of the uterine artery or arterial embolization, but this is usually if it's refractory. First line is uterine massage. Make sure you know that for atony. If there's any lacerations, then you can repair them surgically if it's greater than 2 centimeters. And if there's any retained placenta, you go in there and you manually remove these fragments. So now we're going to go into endometritis. Basically, it's infection of the decidua or pregnancy endometrium. Basically, during labor and delivery, normal vagina tends to colonize the uterine cavity, and this can become bad. It's more common in C-sections than in vaginal births, and it's due to sometimes prolonged labor, and if there's any rupture of membranes also. If there's multiple pelvic exams during labor, if there's a history of chorioamniotis. Risk factors for endometritis is if there's any immunosuppression, if the mommy's diabetic or anemic or obese. Signs and symptoms, basically there's going to be a fever of more than 100.4 degrees, 2 to 3 days postpartum. They'll have midline abdominal pain, uterine tenderness, and foul-smelling lochia. It's foul. Diagnosis is going to be clinical with the CBC. You'll see leukocytosis, right? Because it might be this is going to be a bacterial infection. Usually with bacterial infections, you see what? Leukocytosis. Treatment's going to be with IV clindamycin with gentamicin. So now we're going to go into perineal laceration or episiotomy care. So this is the most common complication to pelvic floor during delivery. So an episiotomy is an incision made during childbirth to widen the canal. So sometimes if the baby's really big, especially if the baby is those macrosomia babies, right? Then you might need to do an episiotomy so the mommy can deliver the baby if it's vaginal. Some other causes are forceps delivery, if the mother has never had a baby before, if the baby is in breech position. Signs and symptoms, basically it's going to be perineal pain, problems with bowel movements, hemorrhage, painful sexual intercourse, loss of fecal matter through the anus or the vagina, usually in the higher degrees, like your 3rd and 4th degrees. So also make sure that you are familiar with the degrees of episiotomies. Okay, there's your 1st degree, your 2nd degree, your 3rd degree, and 4th degree. And depending on what degree, it's going to tell you how deep the cut is. Okay, 4th degree is like the most severe one, where it goes all the way into the rectal mucosa. So it includes the internal anal sphincter and the external anal sphincter. It goes through all of it. While 1st degree, it doesn't. And that's kind of scary, right, for 4th degree, because it basically is a cut from the vagina all the way to the anus. So make sure that you are familiar with those. We can discuss them real quick. So 2nd degree is going to be a cut through the bulbocavernosus muscle and the superficial transverse perineal muscle. 3rd degree is going to include the external anal sphincter. So it'll include both bulbocavernosus muscle, superficial transverse perineal muscle, and external anal sphincter. And then the 4th one, like I said, it's going to include both internal and external anal sphincter, and it's going to go through the rectal mucosa. So it's almost an entire cut from the vagina to the rectum. Okay. So treatment for this is going to be surgical repair, like an episiotomy repair. You're going to do this with local anesthesia. You can also give the patient some stool softeners, since 2nd degree takes about 2 to 3 weeks to heal. You want to tell them to reduce activity. You can also you can soak the perineum in a sitz bath 3 times a day. Do a sanitary pad, ice packs for swelling. You can also tell them to clean after they go to the restroom, and no sex for 6 weeks. So this can be prevented by doing warm compresses to the perineum, and then a vacuum delivery over forceps if necessary. Okay guys, so just to verify real quick, and I just wanted to hit some high points that we just discussed. So for postpartum hemorrhage, right, there's the 4 T's. What are the 4 T's that are causes? It's uterine atony, retained placenta, lacerations in uterine rupture, and coagulopathy. So those are the tone, okay, which is uterine atony, tissue, retained placenta, trauma, lacerations or uterine rupture, and clotting, coagulopathy. So those are your 4 T's. And what did we discuss is the most common cause of postpartum hemorrhage? It's going to be uterine atony. You'll definitely have a question on that, so make sure that you know that. Okay, and then for endometritis, basically it's a bacterial infection of the endometrium, right? And risk factors, like we stated, was a C-section, premature rupture of membranes more than 24 hours, because that gives you more time to have the area infected. And it tends to develop postpartum on day 2 or day 3. The mom will have a fever, foul-smelling lochia, uterine tenderness, leukocytosis, And treatment's going to be with broad spectrum antibiotics, for example, clindamycin and gentamicin. Alright guys, I hope this was helpful for you guys. As always, if you guys have any comments or if I made any mistakes, feel free to correct me or comment below. Also, if you guys like this, give it a thumbs up, and if you guys do, I'll probably keep making more. I know some of these are pretty long, so I try to keep them as short as I can. And usually what I would do is that I would listen to the medical school YouTube videos for their shelf exam, and I would listen to them when I was cooking, when I was driving, whether I was walking, and repetition is the key, guys. So if you guys had that, or if you guys even have long drives, I really recommend you guys put these videos on repeat. And also, if any of you guys have like mnemonics or cool ways to learn or remember this information, please comment below so you can help other students out. Alright guys, thanks for watching my videos, and I'll talk to you guys later. Bye.